Well, good morning and a very warm welcome to everybody. Good morning to those in San Francisco who are joining us in person. Good afternoon, good evening to those online. My name is Payam Nahid. I'm a director for the Center for Tuberculosis. I'm a pulmonary physician at UCSF and I work in TB clinical trials. And my co-host is Lisa Chen.
The short person mic here. Good morning, everyone. Thank you all for coming. I'm Lisa Chen. I lead the Curry International TB Center. I always like to point out, founded by Phil Hopewell. So where is Phil today? And also in collaboration with the San Francisco TB Control Program. So clearly academia grounded in true public health. So I guess I'm supposed to open with World TB Day is a day commemorating the day Robert Koch announced his discovery of the Mycobacterium bacillus. I think I like to truly think of it as a day when we all, from the TB community, from the TB family, we get together to educate and motivate each other to keep going. It's been a tough few years, but you know what? There's been amazing strides made. We are really making advances, but we need to do more. There's clearly still 1.6 million people dying from TB each year. I think one of the things that still motivates me is that this is something you can care about. This is something we can wake up every day and feel good about the work that we do. So with that in mind, the planning committee and globally, the theme for this World TB Day is now, yes, we can still do it. So thank you all for joining, for all the folks online who are joining. Thanks for celebrating this day with us and motivating each other.
So thank you, Lisa. Indeed, the theme is, yes, we can end TB. And we have much to do in advancing the science and the tools to both inform policy, but improve patient care towards ending this epidemic. It's essential, though, that we maintain pressure and highlight the need for funding for the work that's ahead. I wanted to present to you today that this year, Congress, with the leadership of US Representative Ami Bera, whom you may recall addressed our World TB Day events in 2020 and 2021, has gone ahead and requested an additional $1 billion for USAID's Global TB Elimination Plan and $225 million for the CDC Domestic TB Program. And we're really grateful to Representative Bera for the advocacy and frankly, hearing that the TB survivors, the community, that there's a need and acting on it. So thank you, Representative Bera. This proposal for the 2024 fiscal year budget comes in addition to the $2 billion annual commitment over 3 years for the Global Fund. It's historic 7th year replenishment for HIV, malaria, and TB. However, of those funds, only 20% is allocated to TB, which explains why we need additional investments. All right, so what about us at UCSF and what can we do in the Bay Area? UCSF is very committed to advancing our impact in TB care and TB research. The Center for Tuberculosis has more than 40 affiliated faculty and many staff. And this last year, the faculty and the staff of the UCSF Center for TB were awarded a P30. This is an NIH center grant with our partners, UC Berkeley. The UC TB Research Advancement Centers, or UC TRAC, is dedicated to providing resources and funding for early stage investigators and new to TB investigators. You can think of it as a sort of a mini CFAR, but it's for TB. And our great gratitude to NIH for recognizing the need for a mechanism to support TB, the TB pipeline of scientists. You will hear about our mentorship and training program at UCSF. It's called TB Ramp. You'll hear about it from Dr. Elizabeth Fair later on this morning. In addition, we're really excited to tell our community and our colleagues that in partnership with Johns Hopkins University, KNCV, the Elizabeth Glazier Pediatric AIDS Foundation, and the Treatment Action Group, UCSF is partner and a key leading role in research for a new consortium funded through USAID. This is a commitment of up to $200 million for 5 years to accelerate the research needed for TB elimination. And this consortium is called Smart for TB and led by Professor Chason at Johns Hopkins University. And this program has a suite of technical areas, including ranging from diagnostics all the way through to informing policy and translating results into action in the clinic. So I guess there's optimism ahead, and that's the point of today, and that's what Lisa was pointing out. There's a promise of better diagnostics. We've already seen some advances in therapeutics, and there are some vaccines that are in the pipeline. But today's World TB Day event is going to highlight a slightly different space than perhaps we've done in prior World TB Day events, where we've been more science heavy in the past and giving you the latest exciting updates. This year, we, thanks to the planning committee, have decided to highlight the lived experiences of the people who have survived TB, the people who work in the field daily, the local researchers, investigators, as well as our academic investigators. We'll dive deeper into the challenges that they faced as survivors, as pandemic fighters, and as well as the opportunities that they've seen. So this is the many faces of the TB community, and that's what we're going to do today. And this, I hope you enjoy the program. This is really thanks to an amazing planning committee that's included Dr. Sarah Solomon, Devon Jagannath, Sophie Huddart, Paul Ogongo, all putting in their time to develop this program. Thank you to those doctors. Now, we begin. I'm done with my preamble. So I'm going to ask Adithya Cattamanchi to come up. Adithya is a professor of medicine, a longtime affiliate and partner to the UCSF Center for Tuberculosis, who has now actually become division chief for pulmonary at UC Irvine, but he continues to be very, very closely connected with us and engaged in all our research activities. Adithya, please come up.
Thanks, Payam, and good morning, everyone, and good evening, good afternoon to those online and listening in elsewhere. It's my pleasure today to introduce my good friend and colleague, Dr. Achilles Katamba, who will be giving our keynote sort of address. Achilles completed his training in medicine at McQuaid University in Kampala, Uganda. He's had a long and sort of varied career, which I think has informed all of his research work subsequently. He started as a public health worker deeply embedded in public health programs. First as the Kampala district coordinator for a World Bank funded sexually transmitted infections project, and then serving 6 years as a TB zonal supervisor for Kampala district in Uganda. After that, he completed a master's in and then a PhD in epidemiology and biostatistics with a concentration in health services research. His work was really informed by his time as a TB zonal supervisor. As part of his dissertation, he focused on the efficiency of using a third sputum smear for TB diagnosis. And that work contributed to WHO changing its policy to go from 3 smears to 2 smears for a routine evaluation of TB. After completing his training, he took a faculty position at McQuaid University, where he's now a senior lecturer and leads the clinical epidemiology and biostatistics unit within the Department of Medicine. His research has continued to focus on improving delivery of TB services and improving access and convenience and reducing stigma for people affected by TB. Along the way, he's also been heavily involved in training. He leads a highly successful Fogarty D43 program in Uganda, which is training the next generation of TB scientists. But in particular, what I've really sort of learned from him and about TB research is the importance of engaging communities and engaging stakeholders. So I'm really excited for him to share with all of us his thoughts on building more equitable global health partnerships as we work together to end TB. Achilles.
Thank you, Adithya, for that generous introduction. Good morning to you all and good afternoon, wherever you are. Okay, thank you so much. And as giving me this opportunity really to be here at UCSF, I think to give a keynote as far as the theme really, the many faces of the TB community, partnership between TB researchers, patients, and advocates. And I think in addition, leaving out nobody, probably we need to add on that leaving out nobody. So there are many partners in TB. And the focus is going to be on community engagement and taking you through our journey, how we've engaged since 2008, when I first met Adithya and Luke Davis, who probably left now is at Yale University. And our partnerships have continued and have grown. But before that, probably I will need to say a bit of something today is the World TB. We must end TB and give you some statistics about what is it that in Uganda right now. So the talk is about equitable partnerships for TB research. And I will take you through an example of our work. So my talk will really cover a few sections, statistics of Uganda. We shall look at, as Payam said, a TB survivor story. I will share a TB survivor story for about 3.5 minutes. And you listen in and see what really people go through and the different challenges they go through, so that really meaning that finally we need a multi-sectoral approach to address that. Then we shall go through to look at these different partnerships and the partnerships we have selected, how we approached our partnerships and how they have led to this activity, and also give you some of the examples of some of the studies that have come out and really impacted program work in Uganda, and really see the benefits not only to the researchers, but to the program, the National TB program, the benefits to the staff in terms of career development, and the South-South collaboration that have come in. And we shall give an example of what Payam just talked about, the Smart for TB, which is part of those that we are going to be implementing. And I will end by briefly saying something about decolonization. And I would like to acknowledge a few people. I was invited to the meeting in Nairobi, which was organized by the UCSF Center for Global Health Science. And I happened to be there. And so Puba and team have shared some of their slides, which I will show, which I thought was a good model really if we are to move forward. And I call upon members of the UC Center and other people to join in and see that we really advocate for that and we put it into practice as we do our work. Yeah, I think some of you have not been to Uganda. Maybe it is found in the East Africa, part of out of the 49 countries. And in terms of TB, probably we are high TB, HIV, and 40% of our TB patients are also HIV co-infected. And the incidence is about 199, but the treatment coverage that 82%, meaning 18% of our TB patients never access healthcare facilities. So they remain there continuing to infect. Thus, the need to reimagine TB care. And the other indicators are still below the WHO recommended 90%. And as you know, Uganda is doing well under the leadership of Dr. Stavia, who we are now one of the 6 countries which actually managed to achieve one of the targets of reducing by 35% mortality including Kenya, Tanzania, Zambia, and Bangladesh as the other countries. So thanks for the leadership of our program manager. And that's how TB stands in Uganda, and I'm going to share with you a TB survivor story. Then I urge you to listen in and hear some of the challenges really people go through.
I contracted TB in 2015 during my internship at a healthcare facility because I used to interact a lot with TB patients. By then, infection control systems at the health facility were not streamlined. I was put on several antibiotics, but my condition continued deteriorating. I never coughed, and it was a challenge for the healthcare providers to know that I had TB. I became bedridden and I was taken back to the village. My father thought I was being bewitched and he started taking me to witch doctors. On the other hand, my mother moved me to different pastors. However, my condition continued to worsen. I was taken to Ginger Hospital and the doctor suggested that I start on TB drugs as a trial. After 1 week, I started to improve. The doctor recommended that I continue the medication. Even though I had started this treatment, my father kept taking me to shrines. I was so traumatized with the shrine visits. And I realized that where I was working, we had TB drugs. And so I told myself that I can continue to take them from Kampala. I lied to my father that the landlady had thrown my items out of the house and I needed to pick them. When I returned to Kampala, I showed my medical documents to my workmates and they agreed to continue me on TB medication. After 1 month, I told the clinician that I needed to do a sputum analysis in order to know my progress. She told me that this is done after 2 months, but I insisted and went to the laboratory technician to help me. He feared since the process was not requested by a clinician, but I persisted and he agreed. I induced myself, coughed, and bought sputum, which he gave to a herb rider to take to Mulago Hospital. After a week, the results came back and it was MDR-TB. Healthcare providers started to run away from me because of the notion that MDR-TB kills its sufferers within a short time. They instructed the patient navigator to take me to Mulago Hospital, but still he ran away from me. And the medical manager, after breaking the news to me, she also ran away. It was only the counselor who stood with me, and she told me to go to Mulago Hospital right away, though I went to church first because I was so stressed. On getting to Mulago Hospital, TB medicines were out of stock. I had to return home for a week and was later called for admission. While here, I was under a research center which was investigating the effectiveness of bedaquiline and amikacin. And after 1 week, the cough and lymph nodes completely cleared. 2 months later, I was discharged from Mulago, but continued receiving my treatment from a nearby Dots clinic. And by this time, I had stopped work and things became tough. I had to look for rent for survival. And at the ward, they had warned us not to go back to the village because they would not follow up with us. I was forced to stay in my room alone until I completed my treatment. This was so tough because I had to suffer from side effects of the drugs. I could not walk because the injections had accumulated, and yet I had to continue administering them for 9 months. However, even after the 2-year treatment, I stayed home for another year without a job.
Yeah, that is a story this was a younger lady who had finished Makerere University, and she was employed at a certain place. And then she contracted TB because this was a clinic and probably infection control was not good. But from that story, we can really say there were so many things that happened to this lady. And just to name a few, really, you could say there was a knowledge gap about TB, not only about the healthcare workers, but even in the communities. And maybe one thing, this person presented with no cough at all in the beginning. She had all these signs and symptoms. And as you could see, access to diagnosis was quite really difficult. She forced herself even to tell someone after they are diagnosed. And actually, the doctor who decided to put her on treatment after being in those villages was really saying, because she knew this young lady had HIV, then he just said, let me try the TB treatment when she had come back. And that's when they started, and this was for drug-sensitive TB, started working. And then later on, when she went back and she felt that she's getting better, she said, I need to see what my sputum is. So you could see that the harborider issue, which probably was evaluated in the exploratory, tried to see how do we have these services near the people, clearly comes out in this. Access to diagnosis, bring points of care near the people and others. And this is someone who came from Kampala and a graduate. Imagine those people. Adverse drug reaction, stigma, which is really quite still a big issue. That when they tell you when I was in Kampala and I was the divisional medical officer for Kampala, at that time, there were not MDR TB treatment in Uganda. The patients were always put on the list in Mulago. So this is the survivors. They were put on the list waiting for the drugs. And being the zonal TB supervisor for Kampala, I was asked that there's someone who has failed for TB twice, and we are sending him to you, to your office, since you are the zonal representative and in charge of TB. I also feared, I felt that now it's coming to my office. There are no drugs in the country. Maybe I'm also going to get what? MDR TB. Social support is an issue. This lady was abandoned, stayed alone in her home. That's where no one to talk to, but she managed to adhere. Catastrophic costs, really, a lot of that. And there are many other health systems challenges. So when you look at all of this, really, the things do not involve one sector, health or in agriculture or anything. We have to work together. It's a multi-sectoral approach that we need to work together to make sure that we really address this problem. And if we are to work together, and this brings me to the issue that thanks to the United Nations that recognized that in 2018, and there's going to be another meeting in September, which is really focusing. The theme for this year's UN, which is appropriate, is advancing science, finance, and innovation, and their benefits to urgently end the global TB epidemic, in particular by ensuring equitable access to prevention, testing, treatment, and care. So with that, I think it is clear that if we need equitable access, we need also to work equitably. And I think as I talk about the equitable partnerships that we have developed, giving our example, really we need to work together. And so I'm going to take you through our journey of equitable partnerships between UCSF at the beginning and later with other partners. And this is, we call it the Uganda TB Implementation Research Consortium. And we have a website where it has expanded since then. We really started in 2008 as the Uganda TB surveillance project. And this name, we borrowed it from malaria surveillance project, which was going on under IDRC. And we were also working within those various health facilities where they were working. And the way we started was really, there were many people who would come to, but even before we did that project, I remember I had just finished my training at Case Western. I had returned back to Uganda, and I was appointed a lecturer in Makerere. And I was there the first time. I think either it was Adithya or Luke. He came to my office and said, we want to work together on TB. Then I explained to him, yeah, if we are going to work together, this is, I have a career to develop, you have a career to develop. How are we going to work together? So we agreed on some of the terms of how to work together. The next time, after maybe a month or two, Luke Davis came to Uganda also. He also visited me at my office, and he said, oh, we have to work together. So what is there in for you? What is there for me? And how do we work and other things? And we agreed from the beginning how we are going to work together. So this was 3 people starting this collaborative work. And we started with that small project of really trying to collect data and look at those. Many people would come to the facilities, but would end up not being diagnosed. And we looked at the international standards of TB care. What do they say? And we came up with some indicators, and we really decided to look at it and came up with an intervention to see that we can improve, that even those who come get lost into the system. And that was our initial work as far as the collaborations. And we expanded in 2010 and to support Uganda National TB Research Priorities. And this, we expanded and we talked to the National TB Program Manager. We had more colleagues from other institutions, which are London School. We had expanded to Yale and the UCSF and Johns Hopkins. So at that point, we said, we are trying to address challenges of TB control. How do we address this without National TB Program? So we agreed that if at all we have to have a buy-in, we need to talk to the National TB Program as we plan this. I will tell you, in all the studies we do, or we have done, if you have a concept and you think about it, then share what are the objectives of this, what will be the aims of this study. And we take them to the National TB Program Manager and we present them to him and say, yeah, we think, for example, these are guidelines for TB contact investigation that were put out by the WHO in 2012. And these guidelines probably did not say how should they be implemented. So we needed to look at ways, but we had to pass it to the program manager to say, yeah, but you've not answered this question. This is more pertinent to us and others. And so at that point of developing the concept, and you think it's going to help the program, you need the input of the program. And then finally, once that is done, you move forward and go and look for funding. Once funded, if not funded this year, then you try again and address and still go back to the program manager, because you also need letters of support. You need support that this is in line with what we want. And finally, once funded, the first thing we do usually is to make sure we have what we call the TB Research Forum, which takes place every first Friday of the month. And we make sure that you present your proposal to now this TB Research Forum, which includes beyond the National TB Program, implementing partners, USAID, CDC, MALDME, IDI, and many others, like High Health Sciences Project. They are all on this. So, and then you present the proposal, even which districts are you going to work in, because our districts are divided into different implementing partners. And so you need to say, I'm going to implement in 12 districts. These implementing partners are carrying out this activity. Do they think this is important? Would they want to support it so that the information that comes out? So they need to be aware right from the beginning. And that's quite an important aspect that we have been using as far as collaboration is concerned. So our mission is there. Here we are focusing on TB, trying to make sure that interventions work well. So how our approach have really led us to success. As a team, one of the things is that, as I've already said, we are driven by research priority, which are relevant to these programs, and we involve them at the same level, but not involving them only. This go to, once the protocol has come and gone to the IRB, one of the things that I have seen that is important to engage people. Usually the randomization of trials is done by a statistician, and they say we belong to group A, group B, and others. They come to you and they give you the placebo, and the other gets the active ingredient or drug A or B. However, we changed that, and we started with the EXPERO study, which was led by Adithya. We decided to do a public randomization ceremony. We are going to do work in 20 health facilities. Some of these health facilities were going to be sending samples from the spike to the hub spoke model. Others were going to get the one module gene expert, have it fixed at those 10 health facilities. Now we said, who should do the randomization? We invited the people from the districts, the district health officers. We invited people from the National TB Program. We invited people from the health facilities, those 10 health facilities. Of course, we had already agreed the criteria which facilities to agree with the National TB Program manager, looking at certain criteria. And then we did a public randomization ceremony where those people participated in choosing whether they will be in the intervention group or in the control. The control is where we have the hub spoke model. The intervention will be the ones which will get gene expert. So the site selected which, and they were all very happy at the end of it, and they said this was fair. We shall keep in the control. However, the good thing that at the end of the exercise, they were promised that those who are in the control will be given also one module gene expert, which we fulfilled and gave them 10 module gene expert. And so you could see, once the study starts going on, our work becomes easy. They are engaged, they are involved, they support it. And that's why the trial was very successful and came out final in the New England Journal of Medicine. So one other thing that is key, as I said in the beginning, it's important to agree. Any study has got staff. There are different career developments for different people. And you have to agree on how you will support your staff from our side and the support from this one, so that equally you benefit from that environment and trying to do that. So we did that. So the number of studies which are currently going on from that one surveillance project, a number of some have been completed, others are going on, others are actually new, they are just coming in. And so these diagnostic studies, we also have facility and community-based studies which are going on. And these are collaboration between UCSF, Yale University, Johns Hopkins, and also New York University. There are also studies which are focusing on TB treatment and service delivery. And also, as you can see, TB and social protection study led by Liya, which is really evaluating the impact of cash transfers on tuberculosis care. And this one really was very liked. We went to the Ministry of Gender and we presented what we are doing. Ministry of Gender and labor and social development has got some social development packages, but we are also focusing in health. So I had to go and present to Ministry of Gender High staff meetings to see how do we link these patients who come for TB care and really suffering from catastrophic COVID to existing things within the community. So, and that sort of multi-sectoral. So, as I've already said about engagement, we engage with many stakeholders, and I've explained how we engage with them, different stakeholders. And at the end of the day, there are opportunities for TB service delivery, enhanced policy to support uptake of health interventions. Really, once you work with the people, you find that enhanced health work support to uptake health interventions and improve acceptability and others. So these are things that we found that are easy to go on, like the TB sputum study, which we did. The program manager, former program manager, actually wrote the hypothesis, and he said, if you find that it's more than so many, then I'm going to disband the third sputum smear microscopy. We made him write the hypothesis based on that, and finally, the third sputum was rejected. In terms of career development, I think we have benefited more than the people from here. So you can see that we have a pulmonary complications training research grant, which started with UC Berkeley at Rheingold, then Luke Davis, who held it, is heading it at the Yale, and we are working together. And there are many people who have trained masters, pre-doctoral, PhDs. These are all Ugandans using the environment of our research projects. And that's where we train these students. Global Health Equity Fellows, 3 Ugandans, 1 American. Global Health Fellowship, 1, which is a Ugandan. Fulbright, there are 2 Americans. We create that environment for people to come for. In RSA, 2, and you have 2 diplomats. So this way, people benefit, people have opportunities to grow. And also, this is creating for South-to-South collaboration, supporting other countries. We are working with other countries. In the SMART for TB, those are the tentative list, which was put originally. It may change depending on how things change. Payam knows that things are not always constant in the SMART for TB, they change. We have also, there's another one which is funded by the German government and others, which is going through as called STAIRS. Liya is trying to enhance capacity for research in sepsis. And this is also a number of 7 countries. So finally, this decolonization of global health, which is a model. And thanks, this is the Nairobi meeting, and this is the material. Really, there are now 6, there were 5, but the big 5 has to be under a tree. And actually, I would say that if you have a chance to come to Uganda, and even if you don't go to the national parks, at Entebbe, where the zoo is before you go to fly, you can see all the big 5 from the zoo. They are all there, the big 5. So in case you don't have to go to the zoo, just come early for your flight, take 2 hours, you'll be able to see the big 5. So the acacia tree really is the tree. It represents the ecosystem and provides oversight and guidance for the big 5. And this is work really that has been done by the Center for Global Health Sciences by Group Puba and team. And I think see a very good example. Relationship building. I clearly described how we build relationship over time. And we usually have meetings, investigators meeting, different level of meeting, administrative meetings every month, where our coordinators and investigators come to a meeting and we have. So it's very important to meet regularly. So we meet monthly with the various investigators. Education, training, mentorship, we've clearly demonstrated. Mentorship, we are at different levels. Some are good writers, some have better skills than others, but we can support each other, learn. Not spoon feeding, but support them run through the process. knowledge production and authorship. This is an important thing. In our publications, we have shared them. Actually, I would say one time when we got out our New England Journal of Medicine paper, and Professor Sewankambo, who some of you know, he was our principal of the College of Health Sciences, either is still a member of the Institute of Medicine. He actually said, there are so many Ugandans on this paper and also taking very important positions. He said, this is what I would like what we call decolonization. How would you be a last author if it was not decolonization? So I think we can support each other and we can move together. Yeah. Equity and financial management. I think this is something which has come up. We are given very little overhead, 8%. And the institutions get from, yeah, we do understand the sources come from, but how do we equitably make sure that there is meaningful development of institutions within our settings? See, how do we cater for these at different costs? And somehow we've tried to do that. And recently, when we had the Smart for TB, I was sent a message to say, please send a hardship letter. Then I said, no, I think somehow we shall not send the hardship letter now. Let's try to continue with what is there. And then once everything is signed and others. So I think helping develop the institution and will help a lot. Ethics and community involvement. I think it's important really to look at this very important thing. And if we involve the community, we are doing studies in many districts. There is a current study going on to use artificial intelligence screening. We are working in 12 districts. Another one, we are working in 12 districts. But because we've involved the community and they are aware, we don't have any problems. They know they were part of the interventions. They were part of the randomization. If it is to randomize people, they're part of. Some of them actually came and said, we are in the control. Like the study, which is the CHEST-TB study, comparing clinic versus hotspot. We invite people to decide which are the hotspots in your district. We have information based on the data, case notification, but they also tell us that based on this and this, these are also hotspots. So we identify hotspots with the leadership of the districts, with the healthcare workers. And finally, if we come to do work in that area, they know we did select this and this is where we are going to focus. And the 8 out of the 12 districts are getting that intervention and 4 are not getting the intervention. We are not going to screen they are using at these mobile X-rays. And they said, yeah, we are the ones who chose to be controls. We shall control for you. They go back satisfied and they keep on waiting for the results to come out. So, NDTB, we need to equitable partnership. And I think one of our partnership is trying to make sure that we are equitable. There are definitely things we shall go on and improve, but I think we are trying to live that. And so if we are to do that, I look at the strategic objectives of USID. Here, if we are to reach cure, prevent, and be innovative and sustain TB, we need to equitably partner. And with that, probably I will call on also the UCSF Center for who have made the invitation for me to be here to join this move of equitable partnership so that we can be able to control TB. Thank you very much for listening.
Thank you so much, Achilles, for flying all this way and sharing. I think this is time where we have, oh. Is it on? How's that? All right. I think this is the time we have for Q&A. And if anyone in the audience would like to step up. Or is there anything from the folks online? There's one. Thank you. I think that's Paul in the back. Why don't you
Yeah,
tell
we
us?
have a question online, but it's meant for all the panelists. I would keep it to ask after Dr. Wassie and Dr. Segundo talk, because for all of them, I think Dr. Achilles, Dr. Wassie, and Dr. Segundo will be able to answer that together because it's a cross-cutting question.
You'll ask it later. Well, all right. Let me just, I can start with one of our questions, and I know you guys will think of some more here because this is a great opportunity. Achilles, it really did strike me what wonderfully rich partnerships you've established in your whole group at Walimu. In building a new partnership or collaboration, what do you consider the most important aspects and values?
Yeah, I think to me, the first time really building this relationship, clearly spelling out what is it within this partnership for the key players. And these key players, some may be investigators, but they are also staff. There is the community. So you need to, as you come up with a partnership, you need to look at who are the people who are going to be in this partnership and who our work is going to benefit who. And so that you clearly spell out how you are going to relate, how you are going to share the benefits of that partnerships. In academic partnerships, there is research. Many times we are researchers in our countries, and these countries, our institutions require us to be promoted, and that's based on that. So how are we going to share that? And also, how are people going to have a chance to develop? Because if you bring in a research grant like an RO1 for 5 years, there are many questions that can be answered, which are not the key. Who will benefit to answering these questions and spelling out? And this I sometimes bring it to some of my students when I'm teaching some research methods to people who are doing their Master of Medicine, Internal Medicine, and other disciplines at McQuaid. It's a cross-cutting course. And many times, some of these young men, when they have finished and ladies, their masters, they are invited to work in this project, which is probably an infectious disease institute. And they say there is a research project. And I always tell them that as an adult, there's nothing for free. No one is going to take your time and does not pay you. That's a given if someone says he's going to give you a work. But what is it that you are going to work on? We are going to work on this research project. What are going to be the outcomes? Learn to negotiate that, okay, I'm going to be a research coordinator for this study. There are different studies which will come out. Can you give me a chance to lead one and support me? So that finally, when we have 3-4 publications, I can also be a leader. So to me, I think it is that initial understanding and how you work. And sometimes things may not work well, then you need always to go back and remind people that, oh, this is what we agreed on. And I could give you an example. There's one team which was from another setting. We agreed on phone on how this worked. It was a 6-month type of work. And I was the main person. My colleague Moses Joroba was also working with me. And then we agreed on phone how we shall do this work. And we did the work. And we exceeded even the expectation because it was over 4 countries work. But they told us each one has to do 500. We had done 800 and others had not. Then it came to the final time of publication. Then they said, you are free to publish the data from your country. But after we have published the multi-center paper. So, but then I said, what you've written down, fortunately you brought this late, is not what we agreed on phone. So I will not append my signature on this. And my colleague Moses And you went back and said, this is what we agreed. And they said, yeah, it's true. And at the end of it, we shared the malt twice. So sometimes it may require reminding people. We may say something on phone, but if we agree, then it's still binding like something written down. So I think being clear from the beginning is very important if you are to build a relationship. And sometimes things don't work out. You then go back and remind people that, oh, this is how we are supposed to work. Yeah.
I think that there are a lot of young investigators in the crowd here, and you could appreciate he'd be wonderful as a mentor. You just learned a life nugget. I am.
Oh, there's a question online.
There's a question online, right?
Yes, there's a question from Raphael. He's asking, in that line of what you've just explained, what do you think are the best incentives to build partnerships with agencies for surveillance and prevention purposes? So what are the best incentives to build partnerships with agencies for surveillance and prevention purposes?
Yeah, I think the best incentives, and this is sort of a surveillance, is talking about surveillance project. Yeah, I think all in all, the incentives may not be vary so much depending on where you are. There are incentives of which one I see career development. We always start somewhere and even become experts. Have I given opportunities to learn and be able? If at all there are any incentive to publish or to present at meetings or to write applications and other things, am I given that opportunities? So to me, I think they may be a bit different, but I still look at them. There are also incentives of money, payment, building your career and others. But always I urge my colleagues and others that if you ask me that we are going to work, time is already given, but what is it we are going to work on? And many times I tell people, if I say there is a job and the first thing you ask me, how much are you going to pay me? I don't give you that job. What if I'm telling you to go and kill Adithya? Will you manage the job? It's better to understand the job and understand what is involved. The fact that I'm going to give you the job, it's already given that there will be payment for you. We can talk about it, but what is it that we are going to do and what are they going to be the outcomes? How do I benefit from that beyond just the time?
Yeah.
There's mics, so you may be able to.
So I can just speak up.
I think so.
So thank you so much for the amazing presentation. So one thing we've always struggled with in the African continent is helicopter research. And I love the process of sitting down to determine the terms of reference for what the partnership would look like. How did that conversation look like, and what does the model look like so we can implement that when we start collaborations?
Yeah, I think when you say helicopter, it means that research is done there, implementation, it's relevant from that. No, I think and this has been sort of a protection, and I'll give you back that even our systems, like in Uganda, where I know very well. For example, if you were to come, before people could come and do their own research as an investigator, and even submit an IRB, have it approved, and then do the research, pay people, and go away. Right now, the rules in Uganda, you cannot be allowed to be a solo investigator. You must have a local partner as an investigator. If you were to submit your protocol to the IRB, and this year came with his protocol on, it will not be accepted in the IRB at any level, meaning that there is control to say, where is the research capacity building for the country? And there must be someone you work with to build capacity and agree. In terms of relevance of the research we do, at least in my team, and many researchers are relevant, probably we really, the questions that we have been answering is really to make sure that these interventions, they can also be relevant to other developing countries and others, but I have not seen any research being done to go away. That is sort of both from the policy level, the National Council of Uganda, National Council of Science and Technology, but also from the institutional level. In Makerere School of Public Health IRB, you cannot come and submit your protocol. So it's better you identify who to work with in your area and even right from the beginning. Yeah.
Wonderful words of wisdom throughout your whole talk and the QA. I think I'm getting the signal from the back. I think it's time to turn it over to you to organize our panel. So can we have our panelists come up? Thank you.
I just want to take this opportunity to introduce to you Liya Wassie. Yes, I've pronounced it well. PhD is a senior scientist at the Amma Hansen Research Institute in Addis Ababa, Ethiopia. Our research focus has been on understanding immune responses during TB infection, particularly latent TB, and identifying biomarkers with potential application to improve TB diagnostics and vaccines. Previously served as the site PI for the NIH NIAID-funded TBRU Astra entitled Role of Antigen Specific T cell responses in control of TB. So, Liya, the floor is yours.
Thank you very much. Good morning to you all. It's an honor and privilege for me to be part of this ceremony on the World TB Day and contribute to the ending TB with the global community. So I was given a topic on decolonizing bilateral. So the topic is a bit difficult for me to comprehend, and so I had to go for a bit of research and reading. But partly because I came from a country where it didn't experience any colonization in the past, so I'll try to be as clear as possible. In this project, I came from Ethiopia, from part of the Horn of Africa, and working as an immunologist working on tuberculosis at the Armor Hansen Research Institute. And I came in contact with Professor Ernest and Bloomberg from Emory University and UCSF through this TBRU Astra project since the end of 2017. And we've been collaborating on a study to investigate the role of antigen-specific T-cell responses in the control of TB. And we were mostly active in the recruitment of study participants. And as part of this collaboration, there has been a capacity building, especially in upgrading the lab capacity and doing clinical research in the facility. And in the period of our collaboration, about $1.1 million USD was invested in the overall project conducted at HARI. So my topic is on decolonizing the North-South bilateral relationships. To understand this colonization or decolonization, the impacts seem to be more visible, but somehow overlooked or intentionally being silent to talk and to acknowledge what colonization is in research partnership. So I'll try to touch base on how colonization has been in the high-burden settings, especially in the African settings. I'm glad the previous speaker touched upon about how colonization and ways to achieve or mitigate this impact. But the main issue that I try to project is the funding flow. Even though there is a large amount of funding available to conduct research on tuberculosis, majority of the fund flows towards the north and south settings. So even if the burden of the disease is really high and impactful in the community, the funding research and the flow seem to flow towards the North institutions. And this imposes inequalities in decision-making, in setting health research priorities and in the facilities in hybrid settings, and also somehow imposes practices in poor investment and capacity building, be it in training, human development, or research infrastructure in those facilities, and ultimately leading to unfair sort of benefit sharing, be it in terms of knowledge practices, good implementation practices, or better opportunities for working, or better employment opportunities, or authorship, or whatever is outcome, whatever is coming out of that research partnership. So in my next sort of presentation, I would try to talk about or issues to project some ways to challenge this existing dominance of knowledge production and way of decolonization or decolonizing this North-South partnership. One way would be to look at would be to have a dedicated fund for areas which are really affected by hybrid diseases, one of which is TB, that's particularly in low and middle income countries. And this somehow will give flexibility and trust in the facilities there to conduct research in a flexible way on areas what really matter in terms of the public health interventions or public health priorities in the area. And I also want to make a point here. One of the ways to challenge would be when funds are usually available, there is this mindset that the fund will not be used in a trust way in resource limited settings, because the poverty or the setting we have in back home seem to inhibit the utilization of the fund available. But dedicating a fund probably would give, one way would be to set up a dedicated fund for such settings, so that the health system or the research institution would have flexibility in designing their research priorities to do more applicable and implementation research, or basic science or implementation research, what really matters in that facility. The other point would be respecting research participants on communities in a way that the research priorities or the research activities and initiatives would actually meet the needs of the society at large there, and respecting the values and the cultures of the community, and also avoiding by going the minimal research ethics practices that would negatively impact the implementation of the research. The other point would be to challenge how this decolonization can come up, would be to see researchers to play a significant role beyond collecting or shipping samples, so that they can own research products or outputs, be it scientific knowledge, be it pharmaceutical products, be it whatever is coming out of that research partnership, as a way to consider researchers to play a significant role beyond that. And the last would be, of course, all this will not come out as solely by the partners from the North, but also significant contribution and strong political commitment from the Global South, which is also what is really important in the effort to decolonize health research practices in the Global South, to have a better implementation practices. I think this is I would end my talk, and ready to take any questions. Thank you.
Okay, so
Now, I have an opportunity to introduce to you Segundo Leon is a UCSF Huddart former scholar, infectious disease research, and currently general director of research and social university at San Juan Bautista Private University in Peru. He works mostly on infectious and affects vulnerable populations and has research collaborations in TB studies with partners at UCSF. Yeah, Segundo, you are welcome. Yeah, the floor is yours.
I'm
Please
here.
go forward. Yeah.
Thanks. Good morning, everyone. San Francisco, London, and everywhere else. Well, thank you for inviting me. I would like to talk a little bit about our TV experience in the issue of decolonizing bilateral relationships. So Peru, as you can see in the picture, is a capital concentrated country, as I used to call it. Peru is located in Latin America. One of its main characteristic is that Lima has 30% of its population, almost 12 million people, and also holds more than 80% of the TB cases of the nation, which is very serious. As said in the picture, its transportation system, just one of the main problems we have, is used and surrounded by crowds. This in many places, as you already know, facilitates TB transmission. I mean, this is one of the social drivers of this pandemic in Lima and probably in most major cities around the world. But even with the COVID pandemic, an airborne transmitted infection, also as TB is, crowds were absent. So several political changes and protests affected Peru nationwide. This figure concentrates high-risk social spaces, vulnerable population, and shows a low level of prevention across the population. And this cultural barrier needs achieved. The issue here is to think how to shift cultural belief, which is probably the most critical things to change in a population, especially in those countries most affected by the tuberculosis pandemic. Our approach, as you can see in the picture, is doing laboratory research, but with the most direct impact into the population. So we used to work with the poorest, the most vulnerable, those living in the hills that surrounds the capital, whereas Led Zeppelin and they have a stairway to heaven, and we are trying to work with them very, very closely. So trying to reach them in terms of having them on some kind of care, starting with the research we do here at the university in Lima. But we can explore, talking about decolonizing, the main indexes. So you can see here that we found out that colonialism is represented by publications. So 8 out of 10 institutions making impact using Peruvian TB data are non-Peruvians, and this is one of the things that we should probably work on in the following years. So to end, I have to say that our current collaboration with UCSF Sarah Suleiman's team includes what we need. We need social responsibility, we need resource, but we also need this sort of global collaboration, but mainly technology transfer. So I will let you to be my message, your message. Yo también tengo tuberculosis. Thank you.
Any questions for?
So I wanted to ask, when you have a research partnership that's going very well and you're sort of thinking of your trainees, how do you help bridge that from the research kind of relationship that you've established that you're happy with, how that's working? How do you ensure that that keeps going for your trainees and for the next generation at your institutions?
Thank you for that question. I think what matters is, I guess, as previously spoken, the outcome of that collaboration and research training is really important to the capacity built and lived to the local situation, be it in terms of institutional capacity or skill exchange or knowledge generated, or the product that is coming out of the research collaboration is something which should be given emphasis and value. And for example, if I tell you the experience we have in Ethiopia, mostly when we engage researchers or students in such collaboration or partnership, we usually let the students or the researchers to own the project, so that they have this sense of ownership and belongingness and engagement in what is really from that relationship or partnership. So we try to see the skills gained, the capacity invested and built in the institutions locally, and be it on an author in the publications. That's what we count as an output in that partnership. Yeah, thank you.
Yes.
First, I just want to thank you both for coming and providing, Achilles for providing our keynote address, and then actually now we've given you work to do. You're moderating our first session. So this is a first step towards equitable relationships. But I had a question for you. I mean, I love what I'm hearing. I also really love that you used you chose the elephant to represent the relationship of the big five, because the elephant is a highly sensitive and caring animal, and it's good for building relationships. And I've heard the importance and value of bi-directional, respectful, equitable partnerships, where the ownership is also local, as much, if not more, than the North. Have you seen, though, a shift in the commitments locally from leaders and decision makers to provide the space needed for young, early stage investigators to start to get into research, when so many places I visit, they say, listen, I'm just tired by the end of the day. I work all day long in the clinic. I don't have time. I cannot afford to do this. Do you see a shift over time? And how have you done it in your setting to allow those ambitious young investigators to get a good foot going on their research desires?
Yeah, that's a tough one, but I think if you look at it, we could look at it in two ways. You know, research per se probably is not that much lucrative especially in the developing countries. Making someone survive, it requires patience. It requires patience, people who are patient. At the same time, definitely observation may be good for some individuals, but I would give an example of our own collaboration. Because right now, there is a time when I mentioned something that I want to retire. Then someone said, hey, as you are, but I was trying to say, there are a few people who have come up in our collaboration now who I think can take on. And so far now, since we started the collaboration, we have about 4 or 5 people who have now moved to the next level and trying to create that. And I would say that it's quite, they are where sometimes people say people are not changing, it's the same person, it's the same face doing it. But I find there's too much work, no one can do it alone. The landscape is so big. And I think right now I could tell you many of those studies, some of our PhD students who just qualified recently, they are the readers of some of those TB Reach. The key issue is that we are supporting them to make sure that they do the work and continue to be independent. You need someone to lift you up to do independence. And I think these probably are important discussions between both the North and the South to say here is an idea, who would it fit? How can we help him and others? And one thing that I have seen in which has been helpful, issues of fellowships. In our setting, we don't have fellowships. You want to finish your master's or your PhD, immediately become independent, which sometimes you may not have had hands-on. And so creating these fellowships to have the global equity and other things, and giving people protected time. And then also putting in place, probably one thing that I have seen, I looked at some of the career development plans for faculty here at UCSF. It is very clear that someone will succeed at the end of the day. It's well structured. But sometimes such, and I borrowed from a leaf from some of those I saw, I said, yeah, it's good to clearly put down these milestones and people know, because sometimes we want to be on the top before we go through the steps. Whereas when I look at the career development plan, who is going to help you, at what time you have to achieve to move to the next level and others. And once that is spelled out, then and clear to everyone and what is in for each. And sometimes when you stay on the same place for long and probably it's not helping you, then you may end up, but at least I think those milestones need to be, someone has a target, but these are the milestones you must achieve through that. Probably that may help create a system of career development that can be motivating to people and also give opportunity to younger ones and others. Yeah.
Maybe just to add some points with what has just been said. In most institutions in Ethiopia, for example, we don't have a structured or institutionalized mentorship programs. So that the young, when they come, they don't really know what their career development plan is or their individual plan in their path. They would just see around and say, maybe I want to be this one or I want to be like that, they would say. But it's not structured or institutionalized so that they really have a goal to set, like a few years down the line, from here I will be here, I will reach to this. It's not that really clear. And so such practices, as already said, would be a better way out, or institutionalizing such practices, the fellowship programs or mentorship schemes that would really help strengthen the young to come up.
So Achilles, you allow me?
Yeah, yes, Leon, go ahead.
Thanks. Yeah, I mean, you mentioned mentorship, which is kind of important. I think one of the biggest revolution on the mentorship programs around the world is first that the mentorship is becoming more institutionalized in most institutions around the world, which is quite important. This has been an ancient practice, but probably we forgot that practice for centuries, and now it's coming back, which is quite important. But also what is important now is a mentorship for tackling some specific topics that are important for the global good, which is infectious disease is one of them, and tuberculosis is included. But probably the revolution now is including more women, which is probably important, not only because of the gender equity, but also for having everyone having opportunities to become leaders in the field. You know, tuberculosis probably is one of the fields where most universities work, but even that most universities work in tuberculosis, the impact of the resource is not seen. Probably HIV, which is younger, has received a lot of media attention, has a lot of political attention or investment attention, but tuberculosis is more ancient and probably impacts more of the world, but it's not receiving the attention we need. And probably mentorship advocated to tuberculosis is quite important, especially among vulnerable and women, which are probably, they will take the lead in the future.
We have a question from the moderators, from the online. So a question for all panelists. What do you see as the main barriers to, sorry, I just lost it for a second. What do you see as the main barriers to decolonizing global health? And what is the path forward? Can digital technologies like artificial intelligence be leveraged to make a decolonized global health field a reality? And related to that, do you think artificial intelligence would actually increase problems and colonialism, or would it actually be a tool for advancement in decolonizing global health?
Can I start?
Yeah, go ahead.
Okay.
Yeah, this is quite an important question, as I was written in the Q&A. The issue here is that when we create international health 50 years ago, international health was defined by what the rich countries do that we can transfer to the poor countries. Then we started calling, after the 50s, global health, but the process is almost the same. But the only thing that we added to the international health to become global health is that most of the problems became global because of the internet, because of the information, because of the more flights, because of the globalization process that we are living on. But one of the things that hasn't changed a lot is that we're still having rich countries supporting research in the poorest countries and taking, as we saw in one of my slides, taking this knowledge, it's a kind of appropriation. I mean, this is where we produce the information and this is where we publish the information and give it to the world, which is probably fine because they made the big investment. But I guess if we are committed to technology transfer, which should allow the creation of local teams that can take the lead and also can implement and also can create through mentorship, through their own investment, and through their own technologies, tackling some of the infectious diseases as tuberculosis, probably.
The only point I would add would be access to these practices and products, which are really one of the major barrier I would say is access and obligation to share whatever you have, whereas you don't really gain in return. That's the main barrier, I would say.
Yeah, I think some of I think some of these advances probably may make it even better. The key issue would be agreeing in principle. What does this partnership mean? What is in for us? Because before, I was earlier on talking to Adithya, and he has not been traveling of recent where the studies are going on. But probably would say, once you've established an equitable partnership, things are still going on. And we could say Zoom and other methods have made it even easier to see that we can communicate. There are so many people now online. So my thinking is that whether artificial intelligence or as this, probably thinking through how do we benefit as partners in this? Is it in terms of knowledge? Is it in terms of resources? What are the ethics and any other issues which are involved? So to me, I think irrespective whether technology comes in, I would think the key message is that following those principles and any other and agreeing on how to relate as moving forward will be so instrumental for keeping a partnership equity. And this may be different from different settings, because when I was in the Nairobi meeting, I realized that the impact of colonization may not be the same for every setting. And sometimes what you may call decolonization may mean something also different in different settings. And so it will be that how do we relate and partner equitably?
Yeah, I mean, people mention A&I, which is important, but we shouldn't forget the basics. For example, in tuberculosis, there is one issue that we haven't solved in 200 years, is how to collect samples from children. I mean, we have A&I, but we can still collect adequate samples for diagnosis tuberculosis in children. I mean, it's not A&I need probably there, so we need to go back sometimes to the basics.
Thank you for this conversation. Much simpler than AI. I was struck by Achilles in your presentation, and also Dr. Wassie in yours, finances, and the amount of kind of equity and finances that's at the heart of a lot of challenges in decolonizing global health and in operationalizing other components of those relationships. I was also struck by how much negotiating has to occur. And I'm wondering if, in your opinion, there is a role for regulating these types of relationships to take some of that heavy negotiating out of the picture. Meaning, for example, most funders don't specify how much money has to go to local sites. If you're partnered with equitable and decolonized focused partners, perhaps it's easier to do, but not always. I'm wondering if there have been conversations about how to advocate that and how we as a center could help in those conversations. The second part of the question is local, which is it seems that those who control the money have a power dynamic in their favor. How can we help advocate for more resources to be available locally to support locally driven research?
Yeah, I would start with the first one. And I think probably regulation will come when ourselves who are partnering feel that it is important to be equitable. It makes it easier to put any regulations. The regulators will see that the partners themselves, really, this is what they want. And I think that may be at one point. And it appears like, for example, this it's an NIH policy of 8%, and it's not something. And we've tried to negotiate to see how can we do better work even within the 8%. And somehow institutions have supported some activities to continue being able so that we move forward. But at that level, you could see, I remember Professor Sewankambo asked the former director of NIH in one of the meetings that why are you giving us on the 8% when you see how the institutions are? And he could not answer that question clearly in a way, and he even referred to it another time and said, Nelson there asked me a question, and it's a very difficult one. So I would think any of those, to me, I think for us, let's build equitable partnerships, try to see that this is the way to go. And probably regulation is something sometimes very difficult, especially if you may not have the resources to say this is it. But how do we do this within a system that supports people who are doing it and creates a conducive environment where we can continue to work? And I think we are left with only 1 minute, and unless there is one question, then probably we'll be closing this session in 1 minute. Yeah.
Just a quick one. Thank you, Dr. Achilles, Dr. Wassie, and Dr. Achilles and Dr. Wassie. You highlight that there is no structure, right, on how to progress. And out of that, I just wondering, when you have these discussions, because you already identified them as the scientists and contact persons, is there any reception from the management of the university, the top management, and how do those discussions look like? Because you could be diagnosing a problem, which we all agree, but there looks like there will be no effort on the process of having it implemented. Just your experience with having that discussion with universities or hospitals to have this structured way of progression for young scientists.
Maybe that was what she mentioned about a clear career development process, but I think we do have career development plans in our institutions, how people move from one level to the other. But a detailed level of how someone moves at individual level to the others, and this may be mainly because of also limited resources, may not be as conducive as what we have seen developing people. But there is definitely a structure of how to support people move out. How well it is compared to what I have seen as the UCSF structure, probably I would want ours also to be developed to that level. Because when someone comes in as an assistant lecturer, and how he will move from that level to go in to become assistant professor, then associate professor, in terms of career development awards, when you write a K43, how you write these others, and MBChB may not be, and the support, the mentorship he gets from the different institutions probably may not be there. So it's not as detailed, but there is definitely a structure for career development. Yeah, so maybe I will close this session and stop there. Thank you very much for coming, and thank you presenters, Segundo, Lisa, thank you so much.
Thanks to you.
I'm not sure if I'm waving anyone. Yeah, wave, everybody wave. Can you see us?
I can't. I'm standing on the wrong side of the screen, but everyone else can. Everyone else can.
All right.
Fantastic. Well, thank you very much for having us. It's really great to continue this long tradition of handing over at the end of our day and the beginning of yours, just to tell you a little bit about what we have been doing today and to hear a little bit about what you're doing in California. So we've had a fascinating day. It's been really great, and thank you again to the organizers here. Can't actually see if we have slides. That's fine. I can just read off here. So I think we began by talking about understanding early TB and the consequences of changing paradigms. And I think one thing that I found really interesting there was a talk from a number of people that I know and work with. I didn't realize had taken this approach to building a consensus on what that looks like and the language that we use around that. And the rigorous approach that they took to doing that was absolutely fascinating, going out and reviewing the literature, seeing what has been used in the past, coming together as a group to try and, instead of imposing something on the community, as so often happens, trying to sort of build consensus around how we think about early TB. We followed this with some insight into how we can harness big data, taking big tasks and breaking them down, making them manageable. And I think particularly in the era of ChatGPT, I think this was a really interesting talk or series of talks as well. And there were things like tools for reviewing literature and so on, which I'm sure many people pricked their ears up at, making some of those things easier. After lunch, we had something on new regimens for drug-resistant TB, where we heard particularly about Stream 2 and Practical, which have both been run out of UCL and LSHTM. And there, for me, one of the interesting things was looking beyond the sort of the efficacy and safety and so on. And we had a bit of discussion about what does this mean for down the line for development of resistance to things like bedaquiline, and just helping us to think a little bit longer term and how we protect what we have and make best use of it. We then had a session on preventive therapy. And again, there are big things afoot here. And for me, the path that stood out there was looking at the need for new diagnostics here, and that at a minimum, anything new needs to outperform CRP. And we just finished now hearing from our Steve Lawn TB HIV Leadership Prize winners, Rivandi and Alberto. So it was really great to hear from them about, well, we ended with what gives them hope in the TB world at the moment. And I think that was a great way for me to end this. So over to you in UCSF. What have you got planned?
All right. Thanks very much, Finn. First of all, we're also excited to have our 6th year of transatlantic partnership with London calling as we start our day. We've had our focus for our World TB Day on the many faces of the TB community. We've tried through the program to focus on the lived experiences of those who have survived TB, TB providers, local investigators, the many challenges that they face, the opportunities for continuing our work together, our partnerships. We started off with a wonderful keynote from Achilles, Dr. Achilles at Katamba from Uganda, who set the stage for us on really diving deeper into the power disparities that exist and mechanisms and concepts for fostering more equitable partnerships in research between the North and the South. That led to a very rich discussion around decolonizing the existing relationships, with discussion by Dr. Liya Wassie and Dr. Segundo R Leon, really sharing some of their own insights about how where they see the strain and the pressures from the current existing structure of power in research and TB partnerships. This afternoon, we're going to transition to hearing from early stage investigator experiences and have a wonderful international panel that includes colleagues from recently funded research programs such as Smart for TB, which is a new USAID grant that we're partnered with, and we have a P30 and NIH center grant as well that is recently funded, and with 6 centers funded across the US. And so we have some speakers from those endeavors. We will have a patient advocate panel following that with representatives from the San Francisco Department of Public Health. And then we transition to a fun 3-minute abstract competition that has, I must say, caused a lot of anxiety for a lot of people. And I don't know if the three-minute abstract competitors, how late they stayed up last night, but I hope it wasn't too late, practicing their pitches. And then we're going to close out with, the TB public health from a US perspective, at clinical challenges in our TB heroes with our medical director for the San Francisco Department of Health TB control program, Dr. Janice Louis. So this is great. It actually is beautifully complements your program. I think what we're hoping comes out of this is additional international, and perhaps you'll partner with us, London, highlighting the frankly archaic systems in finance, in the absence of equity, in partnerships with the high burden settings that we work with and are trying to help. And as long as we keep, hammering away at that collectively, I think maybe the donors will listen, maybe the sponsors will listen, maybe our systems will become a little bit better. So that's us in a big nutshell.
Fantastic. Thank you very much. I think we'd definitely be interested in taking discussions forward. So I think with that, wish you a fantastic day. It sounds amazing. I hope you really enjoy it, and we look forward to next year. Thank you.
Yeah. Are you going to the pub now?
Yes.
Yes. Okay. Well, I have one for us then. All right. Take care. Thanks.
Thank you. Cheers.
Wave, everyone. Oh, Madhu. Wait a minute, Madhu. What, you're on the wrong side of the Atlantic.
California, but I'm in this cold, gray London that's raining all the time.
Well, we have rain here too, if you want to stop by on the way back.
Have a good day.
Great seeing you, Madhu. Bye, Fred. Okay, so we in San Francisco, and those online, thank you. That was terrific. I love that. We're going to now move ahead with our agenda. Next, I'm going to ask, well, as I said, our next session is on the early stage investigators. And for that, I'd like to introduce you to Dr. Elizabeth Fair, professor of medicine at UCSF. She's the director of the PhD Global Health Sciences program. She's also co-director director of the TB Research and Mentorship program, which is an R25 that Elizabeth acquired that really funds our mentorship and training cohort and scholars. And she's also co-director of the developmental core of the new P30 UC TRAC in partnership with UC Berkeley, her partner being Dr. Art Reingold. So Elizabeth, thank you very much. Thanks for bringing all this mentorship and training energy for us. And please come up.
Well, while the slides are coming up, I can introduce this a little bit. So before we hear from the early stage investigators panel, I'm going to talk a little bit about some of the opportunities we've gotten recently. You've heard Payam refer to this in introduction, the UC TRAC TB Research Advancement Center. Got slides. Yes, so as I said, before we hear for the early stage investigators, I want to share some of the opportunities that through this new funding we've gotten for UC TRAC that are creating opportunities for early stage investigators and building collaborations here at UCSF. So in brief, the UC TRAC, it's a P30, as Payam said, from the NIH. NIH, I think it signals real investment from NIH in TB, which is very exciting. It's a 5-year grant, similar, as Payam said, to the CFAR, the Center for AIDS Research funding mechanism, if you're familiar with that. And it really is investing in early stage investigators, creating opportunities, creating funding, and creating mentorship programs. So it's a collaboration between UCSF and UC Berkeley. It is led by co-directors Payam Nahid from UCSF and Jeff Cox from Berkeley. It's divided into 3 different cores. The basic science core is led by Babak Javid of UCSF and Sarah Stanley of UC Berkeley. The clinical science and population core directors are Priya Shetty and Patrick Phillips here at UCSF. And the developmental core, which really focuses on training and mentorship, is led by myself and Art Reingold at UC Berkeley. And really at the heart of the TRAC is our program coordinators, program managers, Sarah Hutchison, who you heard from earlier, Barbara Alonso, who is here, and our latest addition, Thea Sigerson, who can answer any questions you have about some of the materials I'm going to present today. So I just have a couple slides to give an overview of what we're building through this new funding from NIH. And the first is around funding opportunities. The first really innovative program that TRAC is building is a voucher program. So recognizing that the barriers for new and new to TB investigators to engage in basic science research is often very high. This voucher program is designed to support investigators to really test their hypotheses, reagents, new models in vitro and in vivo. So the vouchers will provide some initial support to be able to provide salary support to a trained personnel to help with experiments. And the idea is really to get just that first step in getting proof of concept, some preliminary data. So they're for potentially a collaboration, for a research grant, et cetera. So they're short-term, 4 to 12 weeks. The plan is to offer 3 vouchers annually. And I'm pleased to announce the first voucher was just awarded to Dr. John Budzig, who I think is here today. There you go. So congratulations, John. If anyone has any questions about the program, you can reach out to John. But we're thrilled that really trying to reduce the barriers for people getting into TB. The second are pilot awards in TB research. Just a couple of years ago, we started offering the Mentored Scientist Award in TB research through the UCSF RAP system. It's the resource allocation program that is the umbrella for a lot of different funding mechanisms. But it's just in the last couple of years, we've had TB specific grants, which we're thrilled about. So we're offering the Mentored Scientist Award and a Mentored Underrepresented Scientist Award in TB research. These are $40,000 one-year awards. And anyone who receives one of these awards is automatically enrolled into the TB RAMP, the TB Research and Mentorship Program that you've heard a little bit about, and I'll talk about on another slide. So really trying to give early stage investigators funding to start doing their work. We'll also be offering another Team Science Award in the fall, likely. That will be $80,000 to $100,000. So start thinking about that. We're excited about offering that opportunity for innovative TB research. And finally, some of our funding, because of the mechanism in the past, has been limited by citizenship to US residents. With the new TRAC funding, that is waived. So please review eligibility criteria. We're thrilled that it's opened up more. The second opportunity that we're really trying to build and invest in is around resources to facilitate TB research. So the first is a consultation service. So the idea is that early stage investigators or those new to TB can request a consultation through the CTSI, the Clinical and Translational Sciences Institute at UCSF, to get expert advice from faculty at UCSF or UC Berkeley or someone else in the area to really answer questions if they need have a question about biostats help, clinical design, clinical trials design, implementation science, really to get sort of tailored support in a methodologic area. So we're thrilled to build that out. The basic science core is also trying to build out a consultation service. So hopefully that'll be coming next year. We're also trying to build a data catalog, a curated searchable database of clinical studies. So people who might be looking for samples, looking for different data sets to test a question on, that should be available. And finally, the third is a community advisory board. So TRAC is building a community advisory board that will be available to UCSF, UC Berkeley TB investigators to really integrate community engagement in the conception, the design, and implementation of their clinical research. And this is being built in partnership with TAG, the Treatment Action Group. And we really hope that this will be an integral part in study design for both early stage investigators and all of us working in TB research. And the last piece is mentorship and training. As you've heard, we've talked about the TB RAMP, the TB Mentorship and Training Program, which was funded by an R25. It's in its second year, but with TRAC funding, we can really bump up the offerings in terms of TB research and mentorship, specifically working with the clinical, sort of focusing on clinical science and the basic science cores. So we're thrilled to continue to offer this. And finally, what we're really excited about in terms of building out mentorship is international partnerships. And I feel like we had a master class on that this morning already. It's fantastic hearing all of you, Achilles, Liya, and Segundo, talk about this. One specific we know we'd like to do is offering these mentored pilot awards to early stage investigators from our partner collaborators sites. And also really thinking about what mentorship we can provide. And obviously that needs to come from our close colleagues in our partnered international sites. So we're looking forward to that conversation to see how we can sort of, per this morning's conversation, build up what we offer both to our trainees and our international partners. So I think the website is here. It has all the information that I've given you a brief overview is on the TRAC website. Consultation services are open, as well as the TB RAMP applications are open. They're due April 19th. The voucher program and pilot awards will open late summer. UC TRAC is thrilled to co-sponsor this event today and is really invested in building meaningful mentorship and training opportunities to all of our scholars. So now we will hear from local and international early stage investigators. We're excited to have, as Payam said, 2 TRAC early career investigators represented on the panel you'll hear from next. One from UCSF and one from the Johns Hopkins TRAC as well. And this session will be moderated by one of our very own TB RAMP scholars, Sophie Huddart. So without further ado,
Okay, well, enough of these, established luminaries in their field. Let's talk next generation. Getting the meat potatoes here. So we'll see if our esteemed colleagues who are joining us virtually will pop up on the screen. So our goal today was to highlight, hopefully in an international context as well as here locally, how are the early stage investigators of TB doing? What do they need? What are they succeeding at? Why do they pick TB? And how can we sort of facilitate that path to becoming, the next Achilles Katamba, who's here giving our amazing keynote. And look, oh, everyone's here. Amazing. Okay. So I'm actually going to let each of our amazing panelists introduce themselves. And so I'll ask each panelist, please just give your name and your institution, and then just kind of a brief walkthrough of where your career has gone to date. So I'm going to start online just in case we run into any tech issues. Could I ask Dr. Solima Sabeel to go first?
I'm Solima Sabeel. I did my PhD at UCT at Immunology, Division of Immunology, Department of Pathology, Health of Faculty Medicine. So my project focused on preventing post-TB disease. So I'm not sure if anyone could introduce themselves, then return back again to me, or.
Okay, amazing. Thank you. That's a great start. We'll move next to Alex.
Thank you, Sophie. Hello, everyone. I'm Alex Kityamuwesi from Kampala, Uganda. I'm a medical doctor. Recently completed my local fellowship. I've been doing TB research, I think, for the last 7 years, doing several projects focusing on diagnostics. We've also moved a lot into adherence to TB medication using digital adherence technologies, where we've done some good work piloting 99 dots and then other digital adherence technologies in Uganda. I'm really happy to be a part of the team, and I'm excited to share experience with the rest of the team. Over to you. Thank you.
Hi, everybody. Thanks for giving me the opportunity to join you. My name is Jeff Tornheim. I am a junior faculty member at Johns Hopkins and a recipient of a TRAC award here. I completed my medical degree and public health degree in 2010 at Mount Sinai School of Medicine in New York, did a combined internal medicine pediatrics residency at Yale, came to Hopkins for my clinical fellowship, and am now completing a K-23 with hopefully some additional funding coming in shortly. My work is focused on a combination of cohort epidemiology, personalized therapy, and some advanced diagnostics for drug-resistant TB, partnering with a group in Mumbai at the PD Hinduja National Hospital Medical Research Center. We have looked primarily at whole genome sequencing of the bacterium, various host responses, including transcriptomics, evaluation of advanced susceptibility testing, including MICs, and implementation of personalized drug levels to try to limit toxicity. So a variety of different things, but exciting to me and very happy to be able to chat with you all. Thanks.
Great. Well, we're so glad to have you all joining us virtually, and joining us here in person, Suzanne.
Thanks, Sophie. I'm Suzanne Dufault. I'm a biostatistician and current TB ramp postdoctoral scholar here at UC San Francisco. I am very excited to be on this panel, and it's rare that you get asked to speak from a place of lack of expertise, but I have only been doing TB work for about 1.5 years, and my work primarily focuses on improving statistical methods for clinical trial design for phase 2 and phase 3 studies for TB therapeutics. I've had the privilege to work with Patrick Phillips, who many of you know, and it's been an absolute delight to be a part of this community. So thank you.
And if you stick around, you can hear more about Suzanne's research in the 3-minute abstract competition. Okay, so while the audience is thinking of questions, I'm going to use my moderator privileges to start us off for each of the panelists. I think when I think about my own early stage investigator, you know, I came into TB by accident, but I've stayed very much on purpose. And so I want to hear those stories from each of you. How did you end up working in TB? And even on the difficult days, what keeps you in tuberculosis work? And maybe we'll go in the same order. If we could start with Solima.
Thank you, Sophia. Actually, my journey with TB started when I volunteered as a junior researcher to characterize CAT-G gene in INH-resistant mycobacterium tuberculosis isolated from Sudan. During that time, I learned how to use bioinformatic tools to check the quality of the sequence and to align with the reference genome. Actually, my achievement inspired me. I mean, the result of that research inspired me to continue in the field of TB and mainly in MDR, because few researchers were involved in MDR researches, and there's no data about the prevalence or incidence of MDR in Sudan during that time, according to my knowledge. Above all, like being like TB researcher means more funding opportunity. I'm from Sudan, which is classified based on the World Bank, like a low-income country. So it's not easy to find or to hunt funders. Then I decided to apply for a Fulbright scholarship that funded by US government. My proposal was accepted in the first round, but unfortunately, I didn't pass the final stage. So the USA Educational Affairs in the MPC, she was so proud of me. Then she decided to invite me to join competitive graduate club. So in that club, I learned how to hunt funder. Therefore, I used all of these strategies that I learned to ask for a fund. I was so lucky at that time to get like the partial fund from African City for Technology. So I did my master project, which is phenotypic and genotypic analysis of multi-drug resistant mycobacterium tuberculosis isolated from Sudan using 16S ribosomal RNA sequence. The main finding of that project was the novel mutation in RRS gene associated with streptomycin resistance. Then the novel mutation have been submitted in NCBI international database. Then I started looking for PhD. I applied to University of Science of China. My proposal was rejected. Then I applied to Mycobacterium tuberculosis omics research group. Then my proposal was rejected again. Then I applied to clinical mycobacteriosis in University of in Japan. Also, my application was rejected. And finally, I get accepted in UCT by Ritu Galar. He's my supervisor now. So I get accepted in clinical trial. It's double-blinded, randomized placebo clinical trial phase 2B that it's like a proof of concept aiming to use a host-directed therapy to like prevent recurrent treatment and prevent post-TB diseases such as like chronic obstructive pulmonary diseases and bronchiectasis and all of that things. So we used atorvastatin as a main drug. And we also just like all of our participants must pass through PET-CT scan to check if they have any sign of inflammation after completion of first-line anti-TB regimen. So my story will going in TV. Thank you for that.
Yeah, that's amazing. And I think there are several themes that we'll touch on throughout this talk of first off, persistence and congratulations, but also seeing this critical research need and seeing it, locally and urgently, and then running into this barrier of, finding someone to pay for it. So I think we'll come back to those themes certainly. Alex?
Thank you, Sophie. Well, I started, I was initially in malaria, that is between 2013 and 2016. And so when I got funding for my master's, that was through the D43 grant, I think Achilles, Katamba, and Adithya. I went into TB. So when I got opportunity to do internship from Uganda Tuberculosis Implementation Research Consortium, I got involved in one of the projects they were doing. And that's when I got introduced to the world of TB. We were doing social protection, cost and social protection survey, polling patients to really understand the satisfaction with the services they were getting at the different facilities, but also the costs they were incurring as they were seeking diagnostic evaluation for TB. And that's when I learned that really people go through a lot to merely get diagnosed for TB. We initially thought, well, the drugs are available for free and even the tests are free. But actually, for a patient to get diagnosed for TB, they were doing multiple visits. But even before the doctor could suspect that they had TB, they would first, do several tests, different tests not related to TB, get some trial antibiotics, but without improving until they get to another facility where a doctor thinks about TB. And then they send them for diagnosis. Now, the diagnosis is not a one-off. You have to do that, to submit the first sputum sample, then go back home, come back the following day, and submit another sample. So we realized during the surveys that people were even failing to complete the diagnostic cascade. They would sell off their belongings to merely get diagnosed for TB. Now, for those who were diagnosed, again, there was another journey of having to keep picking drugs. Patients would sacrifice an entire day to, wait at the facilities, submit sputum, wait for results before getting the diagnosis. And when diagnosed, they have to pick drugs. The initial, then after 2 weeks, like that. After 2 weeks, they are reporting for the first 8 months, then another course of monthly refills until they finish. So as we went deeper into what patients go through, I realized that it's really a big journey and their costs. It is not just the good diagnostics and free medication, but maybe we need to go deeper into the socio-economic aspects around TB. And so we've done several other interventions to see how we support these patients, but I can tell you it is not a single intervention that can help wipe out TB. We're trying out several things. Maybe if you're diagnosed, how can we keep you on treatment? How can we make sure you adhere? Like I mentioned at the beginning, we've gone into digital adherence technologies, but still, while you say maybe this will help people keep on treatment, along the way they drop off because there are other reasons that need to be explored. Maybe they didn't have transport to pick refills. There are a lot of issues.
I'll give a moment for Alex to rejoin us. While he's buffering, I can just draw out that I'm also hearing, that same story of responding to a very urgent local research need. But because of the work that Achilles has spearheaded, having actual funding opportunities available at that institution to support that work, which becomes slightly a different story. And you're having such a good internet run. Okay, we're going to give Alex a moment, and maybe we'll move to Jeff, if you want to describe how did you end up in the wonderful world of TB?
No, absolutely. So I think similar to other themes that have been brought up, I became interested in TB probably about 15 years ago or so, as I was starting to learn more about the global impact of various diseases during my medical training. And it just became so obvious what a massive and devastating impact this particular disease has on people who fall ill, their families, friends, their loved ones, society generally. And it's just a disease that really highlights the intersection, as everybody here knows, between both the need and the opportunity to improve on diagnosis, treatment, toxicity, post-treatment outcomes, and come together with all the intersections of both our biological and social realities as humans. Speaking to sort of career development, I had interned with the New York City Department of Health and Mental Hygiene in the Bureau of TB Control, which gave me a good exposure in a US context. And then as I got into my medical training and during my residency, I was able to work in a variety of environments where I was seeing large numbers of TB patients every day. And I realized how hard the clinical challenges were, both in the diagnostic space and in the treatment monitoring and the toxicity space. And I wanted to kind of improve on both of those. And that's what led me to go into fellowship, to learn more about TB specifically and TB diagnostics. But the more that I realized, it was less that of all the decisions that I was making and all the mistakes I was likely making, it wasn't only that I couldn't improve on them because I was faulty as a clinician that I was trying to get better at, but it was also that there were all these frontiers for us as scientists, as researchers, as care providers that just needed to get better. I remember speaking with a mathematician a few years ago about how careers are made kind of in the sweet spot of problems that are important, not yet solved, but that can be solved with the tools that are currently available or are up and coming. And over the last few years, the revolutions in molecular diagnostics, PK/PD work, new TB medications, libraries of significant mutations associated with drug resistance through the work of Cryptic, Reseq, and others, finally getting new drugs to limit toxicity and improved availability of some of the computational tools that will help us assess these things. It's just a really interesting and exciting time to be focusing on the TB space as a clinician and a researcher. And so all those things that came out of my time as a doctor and a student, I'm just really happy to keep being a part of the team to try to move these things forward.
Yeah, no, I hear that with it's a very big, complex problem, but it's also fundamentally like a very stupid disease that shouldn't happen and shouldn't kill people. So that is motivating in a weird way. Alex, did you have anything you wanted to add before we kind of lost you there to what you were saying earlier?
I'm sorry I went off, but I was still telling you the journey into the TB world. I think I've along the way made several observations. Like I mentioned, there isn't a single intervention that can wipe out TB, but maybe looking around the social factors around the TB patients and trying to help them live a better life, access quick diagnostics, maybe cheaply, maybe moving services closer to them can be of help. And most of our interventions now have moved to, how can we support people access the services maybe from within their communities. Maybe I'll share more as we go along.
Okay, and then I do believe Solima will rejoin us. She warned that they're having rolling power outages in South Africa, but unlike the General Hospital, they have backup power. And so she will come back in a few minutes. So before we move up to audience questions, last but not least, Suzanne, how did you find TB?
How did I find TB? So
Or did TB find you?
TB, I would say TB found me. And so I am a biostatistician. I had, like Alex, I came from mosquito-borne illnesses. I had previously been working on phase 3 studies to combat dengue with a bacterium called Wolbachia. And so all of my research had primarily been in phase 3 studies for infectious disease carried by a vector. And I was kind of just scrolling through the job postings about this time 2 years ago. And I saw Patrick's posting about the methods work that was, kind of upcoming and novel and needed in the TB therapeutic space. And it was the first job posting that I read where it was like, well, first, is TB still a thing? Which I think is a common question in low burden countries, right? And so the first step was identifying, oh my gosh, like this is a huge problem. And then, oh my goodness, like there are all of these really fascinating questions that we can really contribute to making a better system for solving this problem. So that's how TB found me. And I don't want my passion for statistics to undercut the seriousness of the disease area that I'm very fortunate to be a part of solving. Yeah.
I think many in this room can tell you once TB finds you, it's sort of, you're done. There's no more research. This is the only thing I do. Okay, so I'm going to open it up for the audience questions now. And if you're not feeling chatty, I have a whole list of questions I'm eager to ask, but I will pause. No, we're still thinking. Okay, so I can move on to my questions then, works for me. So I think I want to again go through with each panelist and ask, in terms of if your career goal is, research independence, faculty position, independent PI, if that is your goal, and if it's not, please tell us what your goal is. What do you identify as sort of the key supports or barriers to that path to independence? What's helped you, what makes you feel secure, what has, kept you up at night in terms of, what are you going to get to the top of that mountain one day? Maybe we'll start with Alex.
Sorry, I think I missed the question.
Yeah, so in your path to the next stage of your career, whether that's being an independent principal investigator in research or whether that's something else, what do you see as sort of the key supports, the things that are helping you get there, or the kind of the key barriers that stress you out when you think of that next stage?
Okay, sorry, I'm turning off the video because of the poor internet. I don't know if I'm audible enough.
Yeah, you're coming through fine.
Is it okay? Okay, so I think the support structure available is my strongest support. I have a strong team of mentors. I think that is very key for me. I have mentors here locally in Uganda and in the US, and they have really been supportive. We have in our organization, there is a way we are supported to, advance to the next level. And I think that has been really of great help to me. The other thing is there are a bit of different research projects. I think we tend to have more questions unanswered. Every time you do one research, it leads to another question, which really sometimes ends up getting funded. So in a way, we are learning. I'm learning from a lot of these grants. The other thing is participating. I've been given the opportunity to participate in writing some of these grants by my mentors. And I think it is a good learning opportunity to eventually being an independent researcher who can, win grants. The barriers, I will be honest, I think the biggest barrier has been procrastination. I don't know if people out there are also struggling with this. Sometimes you want to put the best, but end up delaying things. Yeah, so I think that has been my biggest weakness. And I've taken great steps to overcome it, but I can assure you it is not very easy. I think that is my biggest challenge. But in terms of the support structure here, I think we have really good people to support us to that path. And I encourage people to really have mentors, identify the goals, identify where you want to go, and then the people who can support you to get to that goal is very important. Yeah, maybe I'll add on more. Thank you.
Yeah, I know. I'm definitely hearing again the importance of mentorship, but also just those structures that kind of illuminate the path instead of having to kind of guess what it's going to be. Jeff, do you have any thoughts on this?
Yeah, I mean, just to echo the same, both what Alex was saying and what Achilles had mentioned earlier today, a lot of it comes down to mentorship and the human, social, and financial capital that come along with that. I'm a med-peds trained infectious diseases physician, and my K23 was about genotype-phenotype correlations and PK mismatch and other biomarker development. My TRAC supported award is on redefining the molecular clock for drug-resistant tuberculosis with longitudinal samples. Those aren't skills that I developed through my clinical training. And I was really lucky to have mentors who gave me a seat at the table, were very warm, understood what I needed, introduced me to the right people who could be other co-mentors or collaborators or mentees even, and really put me in the right place at the right time. So at what point in my career did I learn how to write a budget or how to understand Indian tax law? I had to have people in front of me who could help guide me through those processes. And to the extent that those structures can be put into place, both at your institution and at the institutions that you collaborate with, that's really the best recipe for success. And I think the TRAC structure is really helpful in that by building up cores and areas of support for both statistical and analytic and project development and design and just idea and collaboration and discussion sections. So those are kind of the key features for me.
Mm-hmm. And Solima, we're glad to see you back. The question I've been putting to the panel is, when you think about the next stage of your career, whether that's, an independent principal investigator or some other type of career, what do you see as kind of the key things that are helping you get there and the key barriers that stress you out about thinking about that next step?
Actually, the key that could support me are available funds. So one of the biggest problems that we've had now, like the funding. Also, I think most of things that could prevent or maybe give us more support. Access to or investment in incentive that encourage researcher to do more, to do more research and to give us more opportunities. Even in terms of integration and collaboration with other researchers and also like collaboration with industry. I think it could like good point that support my career, like to be independent merger. Furthermore, I think that the link or that I could create with other organization, like even non-profit organization, could support us also. Thank you.
Yeah, no, those are excellent points. Thank you. Suzanne, do you have thoughts?
Two quick ones. So one thing that's been really helpful for me so far in getting to the next stage of independence is the TB research and mentoring program. And this isn't meant to be an ad, but it truly has been incredible.
Kind of meant to be an ad.
Yeah. And it's just accelerated my knowledge of what's going on in the area. It's given me contact with people who are working on very diverse projects. And it's very scary to like present in front of people who are way further along the path than you. And so that has inspired a lot of growth. One thing I am struggling with, I echo everyone else, is funding, but in particular as a biostatistician, I'm having a difficult time finding the right outlets for the research that I want to do. And I think it's really critical. We're doing all this incredible work. Everyone's working incredibly hard. We're mobilizing massive teams. But if we don't, at the end of the day, make the most out of that data, we're missing an opportunity. And so it's been difficult to pitch that to funders who are expecting more clinical or more basic science when I'm like, no, we need the stats to work too. So that's my challenge.
Yeah, the funding question becomes very existential when often at this stage of the game, you have one source of funding or one application that you're doing that year. And if it doesn't come through, it gets scary. And certainly finding the right funding that is going to be excited, enthusiastic about your project is quite difficult. Yes, do we want to start with Devin?
This is great, thank you. Just kind of piggybacking a little bit on Alex's point around procrastination, and maybe I'll actually bring Sophie into this discussion, is I think a challenge is an ESI is actually just balancing all the things you have to do. You know, you're trying to move your career forward. You're also just trying to learn how to do things, learn about a new disease. And, you know, as Sophie said, you might be passionate about TB, but there's other external barriers that are actually preventing you from moving forward, including just your wellness and being able to actually have space to live in a place that is expensive, but also have other support for kind of the rest of your life activities. So I was just seeing if you felt if there were any additional support, or if you felt that that was a barrier and you're kind of thinking about, you know, how do we keep you in TB for the next 20 plus years?
Achilles, did you want to add something onto that question?
Yeah, I just wanted to say that one of the major challenges we have in our setting is statistics. And I don't know how she could see how she can support us and be able to build that capacity. It's one of, I think, a major challenge that we think you are welcome to this area, but we don't want you to remain at UCSF. We want you to come down there and also see how we can support our young people to be trained so that later we have capacity clearly. And I think this is something that we've started, but I think there's still a very big gap. And so thanks that you by mistake ended up in TB, but I think you are welcome.
Okay, Suzanne, I'll definitely be adding you to some calls after this. They're all a little early in the morning, but don't worry about it. Okay, but I'll put it to the panel now. I think David's question about the balance of it all. You know, we all, I think we've established we're very passionate about TB, but how do you be passionate about that sustainably? You know, do you have examples from your mentors maybe, or approaches that you've taken to, you know, hopefully establishing a very long and healthy career in TB? Let's see, maybe we'll start with Alex.
Sorry, I think, what was the question? I'm sorry.
Sure. It's a question from David about work-life kind of balance and wellness, and how do you, especially in the somewhat stressful early stage, how do you approach your passion for TB with also taking care of yourself so that you can do this work for a long time?
Well, I think that has been one of the big challenges, and maybe we end up procrastinating on one, maybe career, or because work is needed. So you have to strike a balance. You have work, you have family on one side, and then a career to pursue. So if you say, let me concentrate on career and work, you forget the family, and there you get problems. Once you get problems there, again, you can't concentrate on career and work. So you have to strike a balance. I've seen people say, allocate time for work. Maybe after 5 p.m., let that be family time. Sometimes I carry my laptop from office to home. Now, as you're home, people expect you to give them attention, but you still have some unfinished work. You're on the laptop, not concentrating. So I think there is always a lot of work to do. So you just have to apportion time, dedicate some time to doing your work because you need to earn a living. Then some time for career. And then there should be family time because we tend to neglect the social aspect, which is also very important. Yeah, that's what I can say.
Very sage advice, and we are grateful. I recognize that it's quite late in Uganda, so we're grateful you're giving us some of your family time. Solima, the same question to you, and I think especially it sounds like you've been such a wonderful example of persevering through what sounds like some very stressful periods in your career, and do you have any tips for how you handled that?
Actually, the stress for me is so difficult to stop it, or maybe because we're overthinking most of the time. So unfortunately, sometimes we take our work to home, which is a big problem. As Alex said, it's better for us, like for mental health and for our health, to find time for us. So what I did, I have like adventure group. So at least once a week, or maybe once every month, we have to go out for hiking. I learned how to hike the mountain, which is good. So we're building our brain, and we are building our muscle also. So I think we need something to break, and to return back. I think even better for all of us. So yes, we need to find something. We need to involve in any activity. We have to push ourselves so hard. I know it's not easy. I can say it, but it's not easy. So now it's like 8 or 10. So we need also to, sometimes we stay at in the lab till 9 or 10, but after that heavy lab work, we have to stop. We need like a break for 1 week or something, then we can continue. So my advice to anyone, just find time for yourself. Take care of yourself, then work will come later.
I think that's excellent advice. And now I want a UCSF TB Center Adventure program. Can we get on that? Okay, so I'm cognizant of time, so maybe I'll ask these last 2 respondents to be rapid fire style. But Jeff, how do you sustainably work in TB?
Yes. So first, just to say that what you're describing is real and common, and recognizing that a lot of folks who are at the early stage investigator kind of period of their life just finished a long training process and maybe are starting to pay back their student loans while they have their first job, or maybe are trying to start their family while they're trying to develop their career. I'll say that I experienced both of those things, and I don't know anybody who feels like they've done it well or had the perfect balance. So it's real. happy to talk about it with you later if you'd like. I know that you know how to reach me, but this I think is a big call for mentorship. Actually, like your mentors, the senior folks, the people in the institutions, the people in the centers, also lived through this period, and it's helpful for them to be reminded if they're not remembering it. And a good mentor is going to remember that period and do their best to support you, recognizing that a lot of your grants aren't going to get funded the first time, or they'll get funded, but you have a regulatory delay of a year. So as you do your planning, you have to think not just about those next 2 months, but the next year and a half while you wait for that thing to come in. And you need to be able to be with your family in the meantime. I've also done that split morning night shift and taking weekends off, but it's hard. It's really hard.
Suzanne, you hiking mountains? What's your secret?
Oh, so. Well, I was going to say I'm happy to see if we have time for one more question from the audience, or no? Should I?
I think we can do one more rapid fire question from the audience.
Yes, I'm happy to feed my response.
We'll pick her brain at lunch then. Okay, Midori.
Hi. I want to know how much of training or education have you received about global health research equity, partnership equity, like what Achilles and Liya were commenting, and especially like how to operationalize this training, because I think that you are the future, and that needs to show that we as the global North can be allies, can be really guiding this equity, because we need to, we are in the process of the change. So how much of education receive?
So maybe we'll start, and we'll do this quite rapidly if we can, but maybe Solima, is there formal training at your institution when you're collaborating with people outside of South Africa, outside of Sudan, how to make sure that you as someone in a high burden TB country are benefiting equally?
Yes, actually, I get some funds. It's not like it's training from H3A Bionet Africa when I was in Sudan. Also, there's a lot of available funds. In UCT also, we have to attend many trainings before starting the clinical trials. And we get like accreditation here in South Africa for clinical trial. I get chance to travel to MBChB Italy to attend the confocal microscopy course also, and we have like a regular training in UCT, and also like regular examination to ensure that like you have everything like standard regarding your skills, your lab skills in BSL2 and BSL3 as well.
Yeah, amazing to hear that there's institutional support for that. Alex, if you forgive me, I'm going to skip this one because I think Achilles did a wonderful job of describing how his institution approaches that. Jeff, at Johns Hopkins, what's available in thinking in terms of equitable research partnerships?
So I have had a couple of required and a couple of optional courses that I've been able to engage in. It has to be a part of the conversation in all training programs to be able to make sure that it's done well. And within our individual teams, as we're building capacity, that just has to be an ongoing conversation to make sure that when we have our bilateral research meetings, when we have our site visits, we're making sure to not only lift up the junior folks from our US-based institutions, but also from all of the partner sites. And so that just has to be a regular part of what we do. That's the main way that we've approached it.
Yeah, and I think this is probably going to be an ongoing discussion within TRAC about how we're building that as well, since we have so many really important international research collaborations.
I'll add. Okay, my 2 cents. My global health equity training, completely self-started, and also very well demonstrated. I think on the teams that I have worked on, I've been very fortunate to be in teams that are doing community-based participatory research and doing the kind of randomization procedures that Dr. Achilles described. But I think there's a huge need, especially for those of us who are not yet PIs. How do those of us who feel powerless engage in decolonizing? In a rising tide lifts all ships. How can my career advancement, like Achilles described that first conversation with Adithya, my career needs to progress, your career needs to progress. How can we make sure that the work that we're doing moves all of us early stage investigators up, as well as our PIs, with their own desires? So that's my 2
Okay,
cents.
I think that's an amazing note to end on and really ties into earlier conversations we had today. I hate to cut this discussion off. I think we could all talk about this for a long time. And at a minimum, I feel better talking to other early stage investigators. I hope that you all do too, that we're all facing similar challenges and hopefully we can solve them together. I wanna thank every panelist, especially those who have stayed up very late on the African continent. Thank you so much for being here. I think this was a really valuable discussion. Thank you, Suzanne, for also being here, and Preston and Jeff. With that being said, we're going to move on to our next session, which Paul Agongo is going to introduce our next speaker. I'm very excited for this, and thank you all.
Thank you very much. We are moving to our third session. I hope the first 2 sessions have given you a glimpse of what we had in store, which is less science and more of talking to these things that surround TB research. We're going to the session of patient advocate panel, and you can remember from the keynote speaker, there was a clip of TB survivor from Uganda, and what you could get is the challenges as they go. And I hope you also realize that that particular case was somebody who was very knowledgeable. The fact that she knew she had to take the initiative. Not everybody who gets infected with TB has that knowledge that they can take matters into their hands. So in this panel, we have want to introduce Dr. Janice Louis, who is the medical director of the San Francisco Department of Public Health, Tuberculosis Prevention and Control Program, and assistant clinical researcher in the University of California, San Francisco Department of Medicine. Her primary focus is to ensure continued excellence in clinical management of tuberculosis, provide mentorship and training fellows, residents, and other trainees, and advancing clinical practices in tuberculosis with a focus on the elderly. Welcome, Janice.
Thank you. I want to acknowledge, first of all, that a lot of this presentation could not have happened without Rocio, Agraz-Lara, who gathered many patient interviews for us that I'm going to read. It's going to be more boring a little, but I'll explain why. And then, of course, we have Tay Taylor here. She's going to be our live TB patient that we'll be interviewing, and she's open to questions. Tay is a remarkable story. Okay, so let's see. We're going to overview the basics of clinical diagnosis and management, not because I want to insult you, but because I want to kind of frame what our patients hear when we talk about it, and that'll be the next step. And then we're going to go through some patient interviews that we recorded at least on paper, and then we'll listen to what Tay-Tay's story is. So first, who gets TB in San Francisco? And I just want to emphasize, I'm going to talk about TB in our city. It may apply to the US, it may or may not apply globally, but this is what we know as far as US TB. So most cases are immigrant or living on the marginalized edges of society or even poverty. So we can discuss the challenges of being an immigrant, which composes about 90% of our San Francisco TB population, with the caveat that immigrants are not a monolithic group. So in San Francisco, there are estimates that 45% of immigrants are unemployed and 50% have unmet housing needs. They may live in crowded and poorly ventilated settings, in shelters or single occupancy residences, or in multi-generational households. They cannot speak or read English or speak or read English proficiently, and that makes navigating day-to-day life difficult. Understanding a rental agreement, opening a bank account, paying bills, accessing public benefits, filling out complicated forms, getting a driver's license, using computers or smartphones, or understanding a website are all challenging. Employment for an immigrant is typically low wage and low skill. And even in San Francisco, where we have universal health coverage, understanding the application process and accessing healthcare is a barrier. So some come from places as well where unhealthy habits like smoking and drinking alcohol are cultural norms. So 20% of immigrants in San Francisco are likely undocumented, making them wary of police or seeking healthcare in a government clinic. or even being truthful about where they live or where they work. Discrimination is a concern, and many have escaped situations of violence or persecution, and depression and stress levels are high. So these are the patients that are coming to us. And I think what's important to remember is that most TB patients we care for are already feeling pretty sick. They're scared and they're anxious, and they're also feeling shame, stigma, and guilt. TB, everyone knows what TB is. The diagnosis of TB is making them feel dirty and untouchable and worried about infecting others. So this is how it starts. As you know, most patients will start with TB symptoms that are up there and that everyone knows. So a patient sees a physician or a provider who says, you might have TB and you need further testing of your sputum and to be in isolation. And if you're hospitalized, you need to be in a negative pressure isolation room by yourself. So from that moment on until you are smear negative, your healthcare provider looks like the person on the left. And if you are getting induced sputum, it looks like that person on the right. He's a little scary, but that's actually how they dress up when they're getting your induced sputum in the hospital. And so in this conversation, even though we try to be as neutral and simple as possible in our explanations, this is probably what a TB patient is hearing. You're infectious, you have a potentially deadly disease, you can infect your family and your friends and hospital staff, and you might already have done so. And we need to isolate you because you are dangerous to others. And even this infographic kind of implies that you're dirty and don't get near anybody else. That's a CDC infographic. Okay, and then infectivity is determined by looking at the presence and quantity of acid-fast bacilli, or AFB, in the sputum under the microscope. So CDC says that you can clear a patient and they can be non-infectious after you have 3 consecutive negative AFB smears in sputum collected Q8 to 24 hours. Symptoms have to be better and you have to be on 14 days of treatment or longer. However, if you are still smear positive after 14 days, you remain in isolation until you are smear negative ×3. So this is what the smear positive patient in isolation might be hearing when you're trying to explain this. You have to stay in isolation until you're not infectious, and we don't know how long this is going to be. But in the meanwhile, you can't go to work, you can't go to school, you can't go to the store to get food, you can't go to the gym or movies or anywhere where there are other people. You can't take the bus, you cannot have any visitors. You have to cancel all your plans, including any vacations or visits with your children or grandchildren. And if you are a caregiver, it may be you need to find someone else to take care of your young children or very old persons. And after the TB diagnosis is confirmed, as you all know, we start 4-drug TB therapy. And so here in the US, we don't have access to a lot of combination pills. So 4-drug therapy means 12 to 14 pills a day, depending on your weight. And that's going to be daily for 8 weeks, followed by moving to 4 pills a day for 16 to 28 weeks. It's taken under directly observed therapy, or DOT. DOT is performed either by coming to our clinic, having a health worker meet you in your home or other setting, by video if the patient has a smartphone and has access to the internet, or by the nurse if you're hospitalized. All these pills have to be taken at the same time while someone's watching you, and the typical duration of treatment, as you know, is 6 months to 9 months. All TB medications are associated with adverse events, and so this table here is just a partial list of the adverse events we see with 4-drug therapy. And in San Francisco, up to 30% of our patients have side effects. If you're over 65, it goes up to 40%. The most common are nausea and vomiting, rash, itchiness, headache, dizziness, joint pain, neuropathy, and 10% have serious side effects like liver inflammation or low blood cell counts. The longer and more severe your side effects, the longer your duration of therapy, and some of our patients are on therapy for a year. So this is what a patient is hearing. They're now starting to get overwhelmed, and we're here in TB clinic. You need to take 10 to 14 pills a day, all at the same time, and it's going to be for 6 or 9 months or maybe longer. The medications can make you throw up, have a rash, cause your liver to be inflamed, and affect your blood counts. And we need to send someone to meet you in your home or work to make sure you take your medication. In other words, we don't really trust you to do it on your own, and you have to wait for a health worker to arrive before you can move on with your life, go to school or go to work or whatever. And because TB is an infectious disease that is a threat to the public, you don't really have a choice to not take these medications. So if you are an AFP smear positive case, you are then an index for a contact investigation. Patients are interviewed about where they've been, who they've been with, recent social activities and events. TB staff may visit their home, their work, their church, their school, or other settings to interview their contacts and test for TB. Special attention and urgency for any contacts under age 5 or if contacts are immunocompromised. So this is what a TB patient is hearing next. You have to give us the names and phone numbers of all the people you were in close contact with so we can tell them they need testing for this serious disease. If you've been in contact with children, we need to know right away, because if you have TB and they have it, they're at risk of severe disease and possibly dying. We will coming to visit you in your home and maybe your work site or your school or your church to inspect the building where you live and interview people you were in contact with. So in this initial visit with us in TB clinic, after hearing about the medications, the isolation, the DOT, the contact investigation, our patients don't look happy like this. This is a CDC image. They're pretty upset and anxious and angry and frustrated. Okay, so let's move on to TB patient interviews. And again, I wanted to give you that context because I wanted to put you in the mind of what a patient is going through when they hear they have TB. So Rocio interviewed or tried to interview many, many people for this talk. I give her so much credit. Most declined to appear in person due to concerns of stigma because they didn't speak English very well or being recognized by family, friends, or their community. 8 volunteered to provide anonymous written responses. All were non-US born and don't have English as their first language. All experienced being in isolation, required hospitalization, and had side effects to medications. Now, on the bright side, some patients took the opportunity of having access to someone visit their home and a nurse to call for several months to make healthy life changes. So there were some positive things that came out of TB care, but in general, I don't think anyone looks back and says that was a great experience. So let's go through these. 30-ish-year-old healthy male professor from Brazil diagnosed with cavitary TB in isolation for 40 days. I was surprised and in shock. It scared me that I coughed up blood 2 days after I stopped quarantining from COVID. I didn't think this could be TB because I had taken a TB vaccine when I was a child. I was part of the 4-month treatment protocol. In the first 3 weeks, the medicine made me dizzy and nauseated. The nurse from the clinic helped me a lot. They saw me every day. They gave me ginger candies, which helped me deal with my upset stomach. The complete isolation was hard because it was summertime and I had planned to go see my family in Brazil. I was not comfortable with knowing that others knowing that I had TB, and I wish people understood that TB is a disease that can affect anyone, not only a few segments of the population. TB treatment can be long and hard in the beginning, but it is doable. So our next patient is a 58-year-old male from Bosnia with severe cirrhosis from alcohol use and isolation for 4 months. After treatment was started, he was hospitalized for liver failure. Terrible, really, yeah, I have that. The first doctor told me I had pneumonia. I had many questions for the TB doctors. Where did I get this? Where is this coming from? There were many challenges: stress, side effects of the medication, side effects of quitting smoking and drinking. I was nauseated and throwing up while changing my diet and habits. Staying home was hard. I missed going in public and I missed work and my body was a mess. The neighbor was always watching. I told the health worker who delivered the medicine, please don't stop at my house, meet me across the corner. When people find out I have TB, they say, I have to be careful around you, man. I got lots of support from the clinic. The incentives were helpful for getting food. The nurses gave me courage to keep going. 20-ish-year-old female from Guatemala. This was a new mom, hospitalized for pleural TB. There were many pills and discomforts, especially nausea. Being in the hospital and my new baby at home without me, stopping work and being in the hospital was hard. I couldn't go to work to pay my expenses. I got sad and desperate. I felt bad when the nurses in the hospital put on all of their gear. I didn't want to make anyone sick. 27-year-old male from Honduras in isolation for 3 weeks. I didn't know what this was, and they said it was a very dangerous disease. I felt very confused. I felt weak and was worried about losing my job, not being able to work and pay my rent, not being able to send money to my family, not knowing what was going to happen. I thought I wasn't going to get out of the hospital. Every day I asked when I was going to leave, I felt desperate. When I realized I was sick with tuberculosis, when they realized, People and friends did not want to get close to me. 37-year-old male from Mexico with cirrhosis and hospitalized for disseminated TB and isolated for 18 days. I was surprised, not knowing that this disease was malignant and I was going to die. The nausea and dizziness, I was traumatized. Not knowing what would happen when you take so many pills at once, would I survive this? Being alone in the hospital without having someone to support me, not knowing what was going to happen. Loneliness is hard, mentally overwhelmed without being able to hug and kiss anyone, thinking that you can infect your loved ones, and nobody came close to me. I was worried, and that is why I do not share with people about my illness. I don't want to feel the rejection. I was grateful to take the pills by VDOT, the Safeway cards, the bus ticket, the services of the nurses and doctors. All the attention to my disease has been very good here in this clinic. 53-year-old female from Mexico with rheumatoid arthritis who was on immunosuppressive drugs and hospitalized for disseminated TB. This patient actually was told she might have ovarian cancer. The hardest part at the beginning was nausea, death because I thought I was going to die because I couldn't breathe. That's why I thought I wasn't going to get out of this, and several doctors told me it was cancer. When I told my family I had TB, they told me this disease was contagious, and in fact, one of my sisters who lives nearby, when I went to her house, she put on her mask and offered me something to eat, but sat far away. And when we finished eating, she told me to take the plate to my house because she didn't want to catch it. All thanks to TB Clinic, I feel good. First, they could speak to me in my language. I am not working in the cards and bus pass they gave me helped me. Another thing that makes a difference is that now I use the phone application to take my medicine early. Tuberculosis is not a game. In my case, I didn't even want my husband to get near me because I didn't want to infect him. I felt bad that I even cried. After I received the information from the clinic, I realized that it was not how people had told me. Don't worry, with God's willing, they will get out of this disease. 79-year-old male from China, hospitalized for 1 month with miliary TB. When I was first diagnosed, I felt very scared. Given my age, I was very concerned if it is curable and life-threatening. When my friends and family knew I had active TB, would I be discriminated? The hardest part was the adverse side effect, which was the whole body itchy. It was very hard to tolerate. The main challenges were also waiting for DOT every day, which had conflict with my daily life and work. Being diagnosed with TB is better than being diagnosed with cancer because TB is curable and treatable. If active TB does not get treated adequately and properly, it may relapse many years later. I'm a good example because I took active TB treatment in China 20 years ago already, which might not be adequate, and that's why it relapsed now. And then finally, for this portion, a 28-year-old male with HIV from Ukraine, hospitalized for weight loss and a new neck mass and diagnosed with MDR TB. He had entered the US from Mexico and was detained by Immigration and Customs Enforcement and placed in a shelter for several months. He then moved to the Bay Area to stay with a friend, but was asked to leave after he was diagnosed with TB. He was in isolation for 2.5 months. From the second week, I began to feel very strong, large side effects: weakness, drowsiness, sudden mood swings, nausea, joint pain, swelling, distorted taste of food. I was no longer able to live with friends as it was before. I needed a separate apartment that I couldn't afford. It was absence of a full life. I couldn't go to work, couldn't go for a walk, couldn't meet my friends, couldn't go to the store. Constant isolation only exacerbated my depression. I was worried that I could infect someone or that my friends and family would turn away from me. The clinic was warm and friendly and welcoming. I didn't feel like an outcast. The doctors monitored the state of my health and took a lot of tests. The most important thing for me was to help with housing. I would not have coped. I had no opportunity to solve this problem. So that's the last of our interviews that Rocio actually mostly obtained. And now we have the pleasure of having Tay-Tay here. So Tay-Tay has given me permission to give a brief overview. She was 29. You were 29. Born in the Philippines. Tay-Tay's HIV positive and was a crystal meth user. She was hospitalized, diagnosed with TB. She had numerous AFB smear positive sputum. She was isolated for 4 months. I think Tay-Tay thinks it was a year. But what I have on records is 4 months, but it could have been longer. She completed TB treatment after 9 months. She entered sobriety. She was hired as a community health worker in San Francisco and trained as a TB advocate. So I'm going to let Paul take over and interview Tay.
Thank you, Janice, for sharing this, the patient questions and what. I'm not a clinician, but I think what you showed us, what the TB patient hears when you explain to them, I think would resonate with many people here. And it is important that we get into their mind. And thank you, Tay, for agreeing to come here, to be here live and speak to us, but also for that transition, that because you agreed to be the advocate, but as you can see, not everyone is always courageous to come out and help all of us fight the disease. So my first question to you would be, how many doctors did you see before you were diagnosed with TB?
One doctor. I was like hospitalized for 3 weeks, I believe. And then I was in general hospital and they told me that I had a TB. Okay. I remember that.
Okay, that's good. And so once you are diagnosed and then you know you are on TB or you have TB, how did it feel to be visited at home by the nurses or by the care team? How did it feel for you to be visited at home by the care team?
Well, they have no choice to visit me. They have no choice because I have no other people to visit me. Even though I was supposed to be isolated, I have friends who did not understood what TB is, and they're like, "Oh, girl, I want to see you. Let's hang out." They don't know the risk that they taking, bringing me food, bringing me stuff, and then things like just saying hi close to me or shaking my hands put them on risk. And then the TB nurses helped me a lot.
Okay. So I just want to follow up on what you said, was that experience when you are isolated, right? Because you said your friends didn't know, or those who knew thought you are now very infectious. But how was it for you as a person? You are used to your daily life and now you have to be isolated.
Oh my God. It's isolation was really, really hard at first. Well, Netflix helped me with my isolation. I think I finished all those 7 seasons, like all those shows. I catch up on them. And I have a roommate who is like very helpful about the TV isolations that I have. And then I brought to TB clinic to get checked as well. Yeah, I think that was hard for me, especially if my friends wants to come over and then not opening the door for them.
Yeah. So this depends on where you are, but might not apply to you. But did you have any hardships getting to the clinic?
The TB clinic picked me up every time I had to go to the clinic.
Okay. So how are you convinced to now come forward? Now you have been diagnosed with TB, you have been on treatment, and now how are you convinced to now come forward and talk about your story as a way of just educating the public? How are you convinced to come up and talk about your own story?
Oh, like I want to talk about my TB experience every time because it's very people that doesn't know about TB, especially from like me, especially I used to be a prostitute. So basically each person that I see, every client that I see, me not knowing I had a TB, just put them on blast, put them on like risk basically. So I can't text them, each one of them, and tell them I have a TB, and they'll be crazy. Imagine that someone catch TB on me and then they came home, infected everybody else in the house. So that's very, and I'd like to be people to know about TB, really.
Okay. So I'll ask you one more question before I take a break, if there is a question from the audience. So just from my end, this is my last question, then I'll allow the audience if somebody has a question. But my question is, what helped you get through treatment? Because you saw from the recorded interviews, every patient complained about nausea and all the difficulties. So what helped you?
Well, the nausea, I'm actually taking more pills than usually, because it's 14, no? 14 pills plus my HIV pills plus my hormones. So it's like a lot. Every night I get nausea. I eat burnt toast. And people, do you guys know burnt toast? So it helps me not to like puke. So just like calm it down, and just that's all. That's my first thing. But headache, I don't like at night. I still have like headache, especially with the first month, I believe, first month.
Okay, so if there's a question from the audience, anyone who like a question to ask Tate a question? Yes.
Yeah, there's my here you go. Thanks very much, Tate, for coming. If you could be the decider, you could have anything you wanted. And I hope your TB is cured and you never have a recurrence and you never get it again. But if you were in a situation where you got TB again, what would be the 3 things you would change about the care, the treatment? For you, what would be the top 3 things? I cannot do this again unless you change A, B, C. What would those be?
Well, if I get reinfected, I don't want to change anything. I think the support that I got from the TB clinic, it changed my life for better. And then to me, before I had a TB, I was a drug addict. So it kind of helped me became more reliable, more, I became more of like a person really, because I stopped using, and then with the help of these people from the TB clinic, they're like my second family. So I can't change anything. If I was given to be sick again, I can't change anything.
What about the treatments?
The treatment sucks. But I can't change it. I mean, I think it depends on each person. Each people have different like way of care. So I guess I can't really change anything. I'm okay.
One magic pill instead of taking 14.
One magic would be nice. That would be. I would guess. Okay, fine. One magic pill instead of having 14. But I think 14 is, it doesn't matter for me.
Thank you.
Thank you.
Any other question from the audience? Okay, so I have a question which is more close to what Dr. Nahid asked is, what do you wish your care team knew about you? Right? What do you wish your care team knew about you and how you are feeling while you are taking treatment? Because you say you are taking these other medications, but what do you wish the nurses, those who cared for you, knew about how you are feeling?
I wish my nurses to stay away from my ass. They were on my ass because there's one time I was like, oh, I thought they won't find out. So I'm gonna go out and get me some Starbucks, and somebody found out. I was like, what the hell? Did they put like a GPS on those medication or something? But they didn't, so that's the only thing. But then they took care of me really good. They really took care of me really good.
So you have now come up to be an advocate, right?
Yes.
So how challenging is it for you to tell people who have TB, not this audience, but when you go to people who have TB and obviously had the challenges, how hard is it for you to recruit them to be other advocates?
It's not hard for me to tell everybody. Like, that that I'm a transgender woman who is TB survivor and HIV too. So it's like a lot of what's that word? Branches, basically. So I have no shame of my game. You know, if I had no shame in my game doing what I was doing back in the day, I have no shame in my game on now. Like I want to be like people look at me like, oh, I was that like that. You know, like an example, or maybe like, yeah.
Yeah, so that's good because you have that strong personality that you want to change, which is good. But how hard is it to make others? Because you can't do all this work alone, right? You can't be the only TB survivor advocate in the whole of San Francisco, right? So if you go and ask other stuff, we have gone through this, we have been cured, but we need to talk to other people who have TB. How hard is it to convince others to do it?
How hard to convince? How hard were you guys to convince? It's not hard for me really. For me it's not hard. Depends on other people. Convince someone if they have TB.
And so maybe I see hands up. So that's everyone. So okay, there is Sophie, then not Sophie, Suzanne, Sophie, and then Adithya.
Thank you for talking about your story, and thanks for sharing all of those perspectives. One of the things that I find really unique about TB treatment is the directly observed therapy that feels incredibly invasive. And especially, I mean, I'm not used to having anyone like be that on me for accountability. Was that an adjustment for you? I mean, it sounds like the nurses had a little GPS on you, but yeah, what was that like?
Yeah, it's yeah, you're right, invasive. I was not prepared for that, but I was not prepared for that. I did not sign up for that, you know, like if I just not for me, but it happened. And it kind of helped me to like, they were there. It's like a therapy, really. Like I was there, like, how are you? Simple thing like that, change your day. So, you know, not seeing anybody else, let's say our isolation, seeing George or Taliba one day you were like, oh, it changes everything really. Yeah.
So Sophie, just before you go on, I'll just take a few some questions from the online.
Yeah, Tay, you do realize there's a few hundred people out there listening in, and yeah, they're all fans now, right? And so Sandeep Gahel is asking, well, he's noting that where he's from, medicines like, I don't know if I'm pronouncing this right, Shilajit, turmeric, protein powder, and guzel are useful for speedy recovery of TB along with the standard treatments. But you know, and this is maybe a question for you and your buddy sitting next to you, our wonderful nursing supervisor from the TB clinic, Rocio. What are the things that you found, other things, non-medicine from the TB clinic, that helped you and support you through taking this medicine? So were there any other things? Did you take, I saw one of the people in the quotes used ginger. Was there anything that you found helped you live through this? And then maybe Rocio, you can always, you know, call your lifeline next to you. Right?
Actually, no, it was just burnt toast.
Burnt toast.
Burnt toast. It
All
is.
right, Sandeep, burnt toast.
Burnt toast.
Yeah.
And for some reason, I eat burnt toast, like the nauseous, like die down, or so it doesn't. I can't really tell everybody else to try something.
Rocio, any tricks of the trade as a nurse specialist?
I think there are, you know, people have different beliefs, you know, in natural medicine, and you kind of have to really interview the patient and figure out what's not going to be liver toxic. And you encourage, you know, chamomile tea. I had a MDR patient who kept having GI upset, and you know, he really thought that, you know, MDR treatment back in, I don't know, 10 years ago was killing all his good bacteria. So I'm like, let's try a probiotic. Here's a Walmart card, go get it. And it changed his feeling about his gastritis. Like, he's all like, I'm doing better. I don't know if it was the probiotic, but, you know, there was something else that helped. So I think you really have to interview the patient and really understand what, because I feel like, after working with patients for a long time, it's the medicine and your mental attitude that really gets you well. So we have to work with our patients wherever they're at mentally and physically, and take those two things together and move them forward.
I just have to. There are a couple other things here, but this is just your fan club starting. Michelle Johnson is writing, Tay, your story is so inspirational. When does your book or movie come out? Thank you for making this TV nurse feel proud of their work in TV. So there's a huge kudo. And someone else was asking, was the HIV diagnosis before TB or around the same time? And what advice can you give to a person who is dealing with both new diagnoses?
My HIV was back 2012. It became severe, so it became from HIV to AIDS. That's why I guess this infection just blew up in my alley, and it's kind of like not knowing, like, because I really know already I have TB because of coming from the Philippines. I had the TB test skin, so I already know I have it. I just wasn't sure, especially back when I was getting high. I wasn't sure or not really care about the all those things until it just hits me. At first, I had a pneumonia, and then after that, that's what TB shows up. For somebody, just basically, it's kind of a lot. It's a lot of mental health, really, especially if you just barely get diagnosed HIV. HIV is very like a lifetime disease. So just take care of yourself. I take care of myself, so it's, you have to like think about the future. Like if you take your medication now, it won't get bad in the future. That's what I think. Because if you don't take your medication, you end up somewhere else, like I did. Thank you.
Thank you. So Sophie, thanks for waiting.
Yeah, thank you. Actually, related to that topic, I know we in the TB field often feel we're so far behind HIV/AIDS treatments, where those clinics, they're super flexible, they're very patient-centered, and as amazing as the TB clinic is here in SF, they have these rules of we have to do DOT, we have to report you, and the CDC rule and all those things. Did you feel a difference in how your HIV was addressed and how your TB was addressed from the healthcare system?
No, they were so helpful about my HIV regimen as well. So I give all the medication to them, and then they just put it including with my. So it's very helpful. So basically them coming to me, I did not miss a dose of my HIV meds, and so was my hormones as well. So it's very helpful.
Adithya? Okay.
If it's quiet in the room, there's some more here. Okay, so another fan. I love the honesty and realness. And then someone else is giving kudos out to the nursing case managers because it sounds like they were amazing. But a question from Jose says, did you use a pill box during your treatment, and did it help as a reminder?
Oh, pill box. Yeah, I did use a pill box. The nurses are my pill box. They were my pill box, If I don't show up or did not open the door, they'll kick the door, and that's a pill box for me. And then you have to like show them you swallow the whole thing, and then you'll be like, open your mouth. Like, did you just saw me swallow the whole thing? So I have to open my mouth. But yeah, they were very, very supportive, and especially with my medications. So no pill box for me.
Any other question?
I don't actually have a question. I just want to commend you for coming so far. I'm new to TB, like 6 months new. And I love TB. I mean, it's like a bug that bites you that you want to keep. But I recently lost a patient who would not give up his alcohol, and he died a horrific death. So I just want to thank you for your story. You know, when you lose somebody, it's really hard. And especially my team tried so hard to do anything for this man, and he just chose the other path. And so I just want to say thank you. And I think you should share your story for both HIV and TB patients as much as possible, because it's an inspiration to those who are struggling on how to make a change.
Thank you.
Thank you. I don't know if Dennis, you want to come back, you have something to add. Otherwise, I have run out of my questions, and I'm very grateful. We are very grateful that you came, as you have been told to add down. So, Sophie.
We just wanted to say thank you so much, TK, for being here and for sharing your stories with this little token of our appreciation.
For bringing me here. This is not going to be stopped. This is not the first and last.
Okay, thank you very much. I'll hand over to Alicia or Barbara.
Yeah, I think what you've graciously done is given everyone a few more minutes for lunch. I think there's a lunch outside, and we're back at a little over 1 hour, 1:30. So fabulous. Thank you all.
All right. Good afternoon, everyone. How are we all feeling? Good. I can't hear you, actually. How are we all feeling? Are we ready for this session? So we've had an amazing morning session, and now we're going to turn over to some of our own early career investigators to hear about their work. This is a competition, but this is a friendly audience. We're all friends here, and we're all supportive of each other. We had one fallen soldier, so we only actually have 4 contestants, and a sacrificial lamb who will be used to calibrate the judges. So our first speaker will be Patrick Phillips, and just to remind the judges, we're scoring on the basis of 3 different criteria: comprehension and accessibility, engagement and enthusiasm, and presentation style. And each category will receive a score between 1 to 5, no decimals, just, you know, just integers, please. And for everyone, please relax. This is a friendly community. I think scientific communication is a skill that we all need to learn. We need to be able to communicate our research to the public. So with that, we'll bring a non-ESI who volunteered willingly to become our sacrificial lamb and calibrate the scoring system. So thank you. Welcome, Patrick Phillips.
So let me ask you a question. I want you to imagine for a moment that your doctor has just told you that you've been diagnosed with tuberculosis. So some of you in the room have been there, and actually none of us, given this morning, have to imagine that very difficult. It's not very difficult to imagine. So the question for you is, how does your doctor decide what treatments to offer you? How does the doctor decide? Let me ask you another question that perhaps all of us have faced. When you had your vaccination against COVID, when you had your COVID shot, how did you decide? How did you weigh the risks and benefits? So let me rephrase that then. So the answer you might give to that, you might say, I follow the science. That's what I hope you'd say in that context. And that's a good answer. My question to you is this: how do scientists follow the science? How are the scientists confident that the COVID vaccine that you had was reliable? The reason we know that is because the main study that was done to evaluate the COVID vaccine was what we call a randomized controlled trial. So let me explain to you what a randomized controlled trial is. Those that participated in the study were randomly split into 2 groups. I'm heckling from the front row here. 2 groups. One group was given the COVID vaccine, the vaccine that was intended to prevent COVID, One group was given a harmless injection. That's what we call a placebo. At the end of the study, the group over here that had been given the placebo, far fewer of them had had COVID at the end of the study, whereas the group over here that had had the COVID vaccine, sorry, the other way around. Okay, so let's start again. The group over here that had the placebo, far more of them had had COVID by the end of the study than the group over here that had had the COVID vaccine. And because the two groups were split randomly, we have confidence that it was the vaccine that led to that difference. So let me go back to the first question I opened with. How do TB doctors, how do scientists decide which treatment should be offered to persons with TB? We need randomized controlled trials in TB, and unfortunately, we've not had enough of them. You heard this morning that TB treatment sucks. We have not had many randomized controlled trials. Many types of tuberculosis, particularly drug-resistant tuberculosis, really scientists don't have very much confidence in the treatments that are offered. So my work is to help to change that. My research focuses on designing randomized controlled trials for new treatments for tuberculosis to really improve the evidence base and to help doctors and scientists make the right decisions about which treatment they should offer to their patients with TB. Thank you.
Up to our sacrificial lamb. Thank you, Patrick. Randomize this. All right. Our first official contestant is Dr. Shoshana Jha, and she will talk to us about her research. And one thing I forgot to mention is that if you pass the 3-minute limit, you will be disqualified. So make sure you're within the limit. And Sophie's there to give you 30 seconds and 10 seconds left. Please.
Tuberculosis is a devastating disease caused by an infection from bacteria named Mycobacterium tuberculosis. These bacteria have lived with us for centuries. So why is it that our immune cells have not learned how to effectively kill them? To understand this question, we first need to understand how the infection occurs. Through decades of research by my mentors and scores of others, we know that when somebody with tuberculosis disease coughs, they release a couple of bacteria into the air, and another individual can then breathe those bacteria in. The bacteria go to the end of the airway, where a cell whose sole job is to protect us from such infections eats it. But the bacteria does not die. Instead, it grows and it replicates and it pushes that cell deeper into the lungs. There, it kills that cell, and other cells that came into fight, it infects those cells. That is the basis of my research question. How does Mycobacterium tuberculosis build such a strong foundation for its home in cells in our lungs? You see, those cells that infected, those are immune cells, and they were deployed to fight the tuberculosis. They came into the area as young, immature cells, and they grew into more mature and for all intents and purposes should be able to kill bacteria. So why don't they? Is it because Mycobacterium tuberculosis pushes them into a weaker state? Or is it just that these cells are inherently too weak to fight against such a hardy bacteria? Our group is trying to answer those questions from different perspectives using innovative techniques. My stance is looking at the individual cell. How does that individual cell react, and what makes it so special and so hospitable to the bacteria? To answer that question, I infect mice with Mycobacterium tuberculosis, let it live for a little bit, but then take the lungs and parse them out into single individual cells, where I can then interpret the internal messages of those cells. I can then begin to understand how is the cell interacting with the bacteria and with the cells around it. Through this work, I believe that the bacteria is actually pushing those cells into this weaker state. And I believe it's doing that through its own machines and proteins that we need to further understand. But importantly, I believe our work is going to inform us how we can help our own cells fight against the bacteria. It's time to use our brains in this battle against tuberculosis because our immune cells cannot do it alone.
Give it up, Dr. Shoshana Jha. Now we all understand what happens to the immature immune cells that meet tuberculosis. Next, we have Dr. Josephine Reineveld. Welcome to the stage. So as we all know, Mycobacterium tuberculosis causes the disease tuberculosis or TB. And depending on where you live, this might be something that you've never heard of, or you just never think about, or it could be something that's just a given, something that's as normal as, for example, the flu. And what we know now after years of research is that most of the people that are exposed to MTB actually never go on to develop active disease. And our team is interested in the possibility that there are these factors within the host and not the bacteria that could cause the development of active TB. So something within the host itself and not the bacteria that makes us sick. And we hope to, with looking into these factors, we hope to find something that we can target so that we can prevent everyone from getting sick. So what we did, we studied this cohort with TB patients and their exposed household context. And what we found was that there was this correlation or connection between a lower production of an enzyme in certain immune cells and the development of active TB disease. So we were wondering what would happen if we got rid of these cells. Would this then lead to a more chance or risk of developing active TB? So within the lab, we removed the enzyme from cells using these gene editing tools. And then what we saw was that in most of these cells, MTB is actually growing more compared to cells where the enzyme levels are just regular. So we think that within the people that have lower production of this enzyme, this means that that the MTB can grow more easily and therefore is more likely to cause active TB disease. And now we're exploring various possibilities and options to find out how a lower production of this enzyme in these certain cells does actually lead to more MTB growth and eventually development of active TB. So we hope to find new ways to fight TB disease, and then maybe, just maybe, in the end, we can keep everyone safe from developing this horrible disease in the first place. Thank you. Give it up, Dr. Josephine Reineveld. Enzymes and TB, maybe we will find a new treatment. Next, we have Dr. Ingrid Biggers. No, not doctor. Speak it into the universe. You will be a doctor.
People go through life unaware of the battles that are fought inside their bodies. Every day, epic stories unfold inside us when our immune systems fight off invading germs. To millions of cells, these are battles of life and death. I'm specifically interested in the Genghis Khan of infectious diseases, a cunning and ruthless invader. I'm studying tuberculosis, or TB, the #1 infectious killer worldwide. When TB bacteria are inhaled, they are sometimes killed by the immune system right away. Other times, the bacteria go all Rambo, destroying tissue and causing symptoms. Or the bacteria can remain in the body in a war prisoner-like state with the potential for later escape and destruction. So why does the immune system sometimes miss the target? And which strategies are pursued when the enemy is killed and let loose, respectively? To answer these questions, we recreate the scene for the battle between the invading TB bacteria and the defending immune forces in the lab. This battle does not take place in Dunkirk or on the Normandy shores. Instead, the battlefield is a cluster of immune cells and bacteria called a granuloma. These aggregates of cells are hallmarks of TB. We have created artificial granulomas or tiny battlefields in the lab using human cells. Because our artificial granulomas resemble those that are found in the tissues of people infected with TB, they can provide some answers to our questions. We can use them to study how the battle progresses and the military tactics of either side. Furthermore, we can decide which immune forces are brought into the battle. Will the bacteria prevail if we leave out the intelligence officers, the artillery, or the Navy SEALs of the immune system? This will tell us which weapons and troops that are most effective against the enemy. Though it might sound like it, we actually do not just work on this project so I can play the scientist version of Risk every day. Understanding the strategies that are effective in killing TB bacteria might be the first step toward new treatments for millions of TB patients. Sometimes the immune system needs military aid, but should we support the infantry, the special forces, or the combat engineers? That is what we hope to find out. Thank you.
Give it up, Dr. Ingrid. Judges, do you need a minute to calibrate, to write down the scores? Are we good? Should we keep going? All right. So we are actually going very quickly, and we will have a lot of time before the next session. So our final contestant is Dr. I thought so. Dr. Suzanne Dufault, who you heard from this morning, and she will tell us about her research.
How do you make decisions? Let's say you and your friends want to get tacos for lunch. Bear with me. The very first step, of course, is identifying a restaurant that has tacos on the menu. But that's probably not the only step that you take in making that decision. There are other factors: proximity, quality, cost, gluten-free, vegetarian options, the list goes on. And you probably do some holistic evaluation of all that criteria to identify the most promising taco shop in your area. So why don't we apply the same approach when we're identifying promising regimens for TB treatment? I'm speaking specifically about how we make decisions in phase 2 TB trials. These small studies follow very few participants to identify whether novel regimens are promising and effective and should be advanced to confirmatory large phase 3 studies. And historically, the decision-making process looks something like this. A novel regimen would be compared 1-to-1 against the standard of care, and the decision to advance it would essentially hinge on a single question. Do we have evidence to reject the null hypothesis that the novel regimen is not non-inferior? Or do we have evidence to reject the null hypothesis that the proposed restaurant does not have tacos? And if you're not confused, you should be. Not only was this traditional way of approaching things incredibly inefficient with the 1-to-1 comparisons, but also we maybe weren't even asking the questions that we cared about, and we certainly weren't equipping decision makers to make more complex decisions regarding the multifaceted nature of TB treatment. Fortunately, there have been advances. Just like Google and Yelp have made it easier to compare multiple restaurants all at the same time, multi-arm, multi-stage studies have allowed us to look at multiple regimens simultaneously. And my work, I hope, continues to add to that advancement. So I want to study the metrics and provide them for decision makers so that they can make informed decisions when more than one regimen is promising. Yes, absolutely, it is still critical that the regimen has promise of cure. But when there are many regimens that meet that expectation, we want to provide information around the strength of effect, whether there's promise that it could be provided for a shorter duration, or a general ranking of the multiple promising regimens so that we can prioritize and advance only those that will be the most promising in phase 3. We need new drugs for TB. And hopefully this work will empower us to bring about the new wave of shorter, safer TB treatments. Thank you.
Give it up, Dr. Suzanne Dufault. So 4 phenomenal talks, and I actually do not envy the judges who have to make a very difficult decision of deciding how to rank these presentations. But I think I just want to reiterate that we all need to develop the skill of communicating our science in very non-jargony, basic, accessible language that we can communicate to the public. So with that, we're actually ready to go on to our next session. Yes. Are there any volunteers to give us a 3-minute abstract elevator pitch about their work? Payam. Any questions to the speakers?
Yeah, I've got this.
Yes, go ahead, Payam.
How much time did it take to prepare those?
More than 3 minutes. Everyone was under 3 minutes though.
Yeah.
Patrick went 1 second over, but we're not. Yes, there was audience interference. Yeah.
I would also like to point out that all the volunteers were women. Men, step up. All right. Thank you, everyone, for a fantastic session. We really enjoyed hearing your presentations. Give it up to all of our 4 speakers and Sacrificial Lamb. Thank you for setting the stage, calibrating the judges, and we will move on to our next session. Thank you, everyone.
Okay, so our next session is TB public health in the US, the clinical challenges that are faced by the doctors here. And I'll just reintroduce Dr. Janice because I suspect there are people who are not here in the morning when I introduced her. So Dr. Janice Luis, the medical director of the San Francisco Department of Public Health, Tuberculosis Prevention and Control Program, and assistant clinical professor in the University of California, San Francisco Department of Medicine. Her primary focus is to ensure continued excellence in clinical management of tuberculosis, provide mentorship and training to fellows, residents, and other trainees, and advancing clinical practices in tuberculosis with a focus on the elderly. Please welcome Dr. Louis.
This is going to be fairly concise, and it's really kind of a setup for the next part, which is about our unsung heroes, TB nurses, both in San Francisco and in other counties. I was given instructions to talk about the clinic, so that's what I'm going to do. But again, I want to focus a little bit on our setup and the heroic people who play a role in taking care of TB patients. So let me position myself a little better. All right. I have no conflicts. So what we're going to do is we're going to talk about the TB patient demographics in San Francisco. So this is going to be very San Francisco focused. Our special projects and collaborations, our clinic team and what a patient experience is going through our clinic. We'll have a break and then we'll talk about unsung heroes who are TB nurses, for sure. So this is a bird's eye view. This is TB epi in the US in 2021. The US overall is a low incidence country, obviously, for TB. And you can see in the middle where it's lighter colored, there's not a lot of TB happening there. However, on the borders on the East and West Coast, there is more TB, and in the South and Texas. And maybe that's because those are more kind of ports of entry for many immigrants. So in the US, the incidence is 2.4 per 100,000. In California, it's 4.5 per 100,000. And in San Francisco, we're pretty hot at 8.6 per 100,000. And again, our incidences are fluctuating quite a bit. We saw a drop of about 40% during COVID. Reasons are a little unclear. We have a predominantly Asian representation in our cases, and we don't know if it was because of shelter in place or maybe just the pause in travel, but we did see a significant drop. We're now on the way back up, but the numbers are still kind of all over the place. So this is our mission, and that's where we are. So as the clinic, we specialize in the diagnosis and treatment of active TB and latent TB. And what I think is a really important component of our mission as well is to educate our city partners in best practices for TB care and prevention. These are our numbers in 2022. We had 59 cases. Normally we have roughly 100 to 110. Our incidence was 7.2 per 100,000. The median age was 63. So just by saying that, we skew quite old in our patient population. 88% are non-US born. 68% from Asian continents, and the most common countries of origin, China, Mexico, Philippines, and Vietnam. So our case rate is 10 times that in Asians and in non-Hispanic white populations. And this picture kind of sums up who we see in our clinic. Because of our older age, 70% have comorbid conditions, usually more than one. 8% report alcohol or substance use, and 12% are homeless or marginally housed. So I wanted to put this up just to remind everyone that patients die of TB in the US and in San Francisco, and it's actually not a small number. So I'll just point out the salient points here. We have significant mortality. Overall, over 5 years, 14% of our patients died, 7% due to TB. And if you're over 65, 28% of our patients died, 14% due to TB. Most of the TB deaths are those persons who present late in their disease course. So a big burden of disease, they come to the hospital, meds are started, but often it's overwhelming infection and they die. So we really need to work more on targeting and educating clinicians to recognize TB earlier and to educate patients if they have symptoms consistent with TB to seek care earlier. It's been a hard message to deliver because of COVID. But the other point I wanted to make is that this amount of death really affects your staff, because I'm here to talk about our clinic. So it's heart-wrenching, it's sobering to take care of these patients. You see them every day, and then a lot of them pass away. Okay, so because we have an older population, we have developed a lot of practices to focus on supporting our older patients. And so one thing that we do is we do a screening mini-cog exam for dementia for every patient starting on treatment, and a frailty exam. So what this helps us do is to assess the patient's ability to tell us, first of all, do you understand why you need treatment? Do you understand why you need to be in isolation? Sometimes we find patients driving, and they shouldn't be driving because they're very old. Sometimes, this is why you need to take your medications. And there are many adverse events that really rely on a patient being able to tell you. They're not objective, they're subjective. Do you have numbness? Are you nauseated? Are you itchy? What is your vision like? A patient has to be cognizant to be able to tell you that they're having these adverse events. So the mini-cog really helps us to kind of say, well, his mini-cog wasn't great, so maybe that's why we're not getting a good sense of what's happening here. The mini-cog and frailty exam help us link to the PCP and say, maybe this patient needs further workup. And it also helps us assess the need for home health, and also talk to the family about the possibility of need for other supportive services. And in fact, about 15% of patients who we screen are positive for dementia that is not otherwise diagnosed. So it's an important, I think, intervention that helps us take care of our whole patient. We are trying to move to VDOT and telemedicine like most of the world. The challenges are that for elderly patients, they're often not comfortable with technology. So that's been a big challenge. We do heightened screening for adverse events due to TB drugs. And we also have our nurses review for drug-drug interactions. So our typical patient will be on 10 or 20 other medications for comorbid illnesses, lots of interactions with rifampin. So we have to be very wary about that. We also are fairly aggressive about treating latent TB in older patients, unlike in other clinic settings, just because our patient population is so old. We have a couple of 95-year-olds right now on treatment that even if, we now have short course therapy, maybe we can get them through it without any complications and prevent any reactivation to active TB. So this is just an example of screening. So this is the mini-cog. It's very simple. It's a 3-word recall. And then we ask a patient to draw a clock with the hands in the right place and to show it showing 10 past 12. And that's a typical patient response. He did not pass the mini-cog, but that's kind of a clue, because otherwise these patients, they sound pretty normal. But when you have them really think about things, you start to understand after a while that maybe we need to look more into dementia or some other cognitive inhibition. And then this is the Edmonton Frailty Scale, and it's kind of a global assessment. So the kind of things it asks about is how many times have you been hospitalized in the past year? How many medications are you on? Do you feel sad or depressed? Can you do things like prepare your own meals, go shopping, use a telephone? Can you maintain your household? Can you do your laundry? Can you manage money? And again, this just gives us a sense of if someone's living alone and they can't do some of these things, maybe we need to look into how we can get them help in some way or talk to family members. We do other things besides elderly care. So we are piloting study 31, the 4-month pilot of INH, rifapentine, moxie, and pyrazinamide. We've been challenged because rifapentine is in very, very short supply. We've had about 15 patients so far. We have developed a nurse practitioner training program with UCSF, and that's led by Ali Phillips. And that's because we really think that the heart of TB care and TB elimination is going to focus on nursing and nurse practitioners. So we want to spread our expertise out into the city. We are piloting treating pregnant women with latent TB infection with rifampin. We're doing that in conjunction with SFGH OB-GYN. This is a somewhat controversial area, but in many cases, pregnant women will lose their health insurance after delivery of child. And so we want to capture them before they lose their insurance, because every pregnant woman is screened. It doesn't make sense to screen them and not try and treat them if you can. So we're working on that. With Dr. Joel Ernst and Dr. Gustavo Velasquez, we have a working group on targeted immunotherapies. That's a fancy name for biologics like TNF inhibitors. And what we're trying to do is characterize other biologics besides TNF inhibitors that can increase the risk of TB reactivation. And then finally, we have a working group with UCSF and their solid organ transplant group to try to kind of figure out what are the best screening practices for pre-transplant patients. So those are just some of the projects that we're trying to work on to improve best practices for TB. This is a big one for us. So we're doing a lot of screening of immigrants, parolees, and asylees for latent and active TB. And this started last year in April 2022 with the war in Ukraine. So the Department of Homeland Security provided a pathway for temporary residence under humanitarian parole for Ukrainians fleeing the war. And most of you might know Ukraine has a high incidence of TB, according to WHO surveillance numbers, and a very high incidence of MDR TB. However, what Department of Homeland Security said was all you need to do is test with an IGRA. And this had us a little bit worried because what we don't want to do is miss a case of active pulmonary MDR TB in San Francisco. So since May, we have been screening with both IGRA and chest X-ray, and we have screened 275 so far. And fortunately, we are not finding a lot of TB. So about an 8% QFT positive rate and one case of active TB that was pan-susceptible. So that's been good and reassuring. It's helped us also pivot so that we can also screen other humanitarian parolees and refugee or asylum seekers. Refugees have funding, they get funding. Asylum seekers do not. There's a big difference in supportive services for these different groups. So we have expanded to screen parolees from Cuba, Haiti, Venezuela, and Nicaragua. And a couple of weeks ago, we screened one newly arrived Nicaraguan parolee. He had active TB, and we were able to start him actually on 4-month HPMZ within 1 day of him reporting to TB clinic. So we're really trying to be very aggressive about making sure that this maybe uncounted population and population that's not easy to kind of coax to come in for healthcare, we're making sure at least that they're not spreading TB in the community. We're trying to be as aggressive as possible. So I hope this is part of the theme of this symposium, but it does take a village, as I've alluded before, to get a patient through TB care. So I just want to show you our village, and it's going to end up with the nursing. But first, there are other people who support our work. So when you come to our clinic, there's a front desk with a screening system in place, and you can see Tamika's there. She's raising her hand because she's kind of hidden. Every patient that comes in, if they have symptoms, we place them in isolation. We accept drop-ins throughout the day for homeless shelter screening and asylee parolee screening. No SF resident is turned away from our clinic. We provide no-cost care for everyone who lives in San Francisco, regardless of your immigration status or your income or your insurance. These are our TB clinicians, Dr. Schmowski and Dr. Phillips, glaring at me. An assessment of symptoms, evaluation, medication review, lab results, all of that goes into diagnosing TB. There's a lot, as I've already told you, there's a lot of education. There's a lot of communicating as well with our radiologists, our pulmonologists, other ID people, HIV specialists. So our clinicians bring it home as far as making sure that every aspect of care is addressed. And then a patient is turned over to our nursing, and you'd be amazed at what they do. So they collect the blood, they collect the sputum, They do all the initial assessments, the mini-cog, the frailty, the vision exam. They talk about the medications in the patient's language. Usually, most of our nurses are bilingual, and talk about side effects. It's really important to be able to talk about these complicated things in the patient's first language if possible. They review for drug-drug interactions. They watch the patient take the first set of pills to make sure they don't throw up. They sign an MOU in the patient's language saying, this is what you're agreeing to do. You're going to take these medications. You're going to stay in isolation. You're going to tell us about any adverse events. They talk about isolation. They get a sense of who's in the patient's home so that we know who's at risk and who needs to come in. And they spend a lot of time when we have a baby or young child with TB or who needs latent TB treatment, because that's really tricky to get a child to take medication. It's a little bit of a battlefield. And so you have to mix the medication, you have to find the right vehicle, meaning Nutella or peanut butter or whatever that kid likes. You'll see a lot of things spit up. It takes sometimes an hour. Our nurses come out all sweaty when they try to get this dose in. And you have to also teach the parents, and they have to show you they can do it. So that is a big effort and time that our nurses are actually very good at. So we have disease control investigators who, I think I've already told you, interview the patient, go into the home, assess for isolation capability and whether it's safe. They will do things like look around for little shoes and other clues that there are children there that maybe weren't reported to them. So that's why, they're kind of detectives. They also go to work sites to see if contact investigation is needed and interview those contacts who are close to a case. Our epidemiologists support the CIs and also ensure accurate data is collected for reporting to CDC. They partially fund us, so that's important to get it right. And they also are tasked with looking at our trends to see if we're missing anything so we can help inform TB policy. We have health workers who are in the field, and I know if you drive through San Francisco, you know how hard this is. So they go to the home or work site of patients and watch them take their medication. They have 10 to 15 home visits a day. They are navigating the world. They talk to the patient in their language if they can, report any questions and concerns back to nurses. And that is an admirable job because they are really out there pounding the pavement. And then the long haul. So our nurses will carry the patients through. We really are a nurse-run clinic. So each nurse has 5 to 10 patients, and they will pack all the medications in those medisets. So you can imagine, there's a lot of medications to pack. And then also if a patient has an adverse event, they have to go on a stop and then they're re-challenged. They're re-challenged one by one. So let's say, okay, you have a huge rash, we're going to stop. And then we're going to try rifampin first for 3 days and see how you do. So every Mediset pack has to have, okay, rifampin for 3 days. And then let's try INH. And then you add in that. So that's a lot of attention and detail they have to do. And I think we drive them crazy as physicians. We're like, no, let's go for a week. And then let's see how it's going. So they have to repack everything. It's a lot of manual labor and concentration to do that. They ask about side effects. They do all the monthly screenings and they flag abnormal results for the clinicians to review. So this is Anna. Anna's packing meds, but also has her iPhone there in case a patient calls, because every patient can call the nurse directly, their case manager, for any questions, anytime. She has her N95 in case a patient walks in for screening or needs to be DOT'd. She's got Epic that's going to show up on her computer to enter everything, and then she's got snacks to keep her going throughout the day. But they're just multitasking all the time. All the time. Okay, and then I went really fast. I'm sorry, I know. But finally, an important part of this is incentives and enablers. And so it takes a village. We get help. We get resources from the state to help us. I just found this ironic that CDC has this picture, it must be decades old, of what they think are incentives. So it's like a pair of mittens and socks, some Kleenex, $1.85, some crackers and juice. And in reality, the incentives and enablers are like life-giving to our patients. They're not supplemental. These are patients who are homeless, who don't have a job, who have very little, means of getting around, and this is their main like substance for a while. And so we actually provide housing. It's not the best housing. It's in an SRO with a shared bathroom, but it's what we have. And so we provide housing. We provide gift cards for $50 a week. So it's not $1.85. It's inflation, $50. They go to Safeway or Target or Walgreens to pick up, hygiene, whatever you need to help you get through. Transportation by private car if you're in isolation or you just can't take the bus tokens, parking, food and snacks. So it is a whole global village that kind of CDC funding, CDPH assistance, local, we all come together to kind of help get the patient through what is really a long haul. It's actually life-changing. It's just sometimes patients will say, I don't know if I was treated for TB. I'm like, how can you not remember? Because 14 pills a day for 6 months, that's a lot. I think you would remember. But to me, it seems like this would be life-changing. And so these are all the tools we have to get patients through treatment. So I think this is my last slide for now. And then we have a break. And then we're going to interview who I think are the unsung heroes, which are our TB nurses, both in the clinic and in another rural county. I think you'll find it really interesting. So thank you.
Dr. Louie, we have 2 questions.
I'm here, yes.
From our virtual audience. The first question is, are there resources for non-English speakers like those you described for the elderly, such as the mini cognitive assessment?
Yeah, so we try our best. We aim to always have bilingual staff because it's just much better for the patient. There's a lot of stories behind every TB patient that you want to hear about. We are able to hit the main languages: Chinese, Cantonese, Mandarin, Toishanese, Spanish. We have a Burmese speaking nurse, but sometimes we miss, and then we rely on interpreters, and that is just challenging. If we have a Mongolian patient, it's very hard. Sometimes there are languages we don't even haven't heard of them before. There are certain dialects out of Mexico where patients don't really understand Spanish. They need something very specific. And so we struggle and we work with our interpreter services to try our best. But sometimes you have to rely on family members to come in and help you.
This is Rocio. We also have the mini cog available in multiple languages. So you can, you have the instructions because it's difficult. And so it's available in, I believe, I've used the Spanish version. I think they have the, Cantonese simplified and a couple of others. So, and you can find those online, or you can email me and I can send them to you.
So there's a second question virtually is, how do the CDIs maintain confidentiality in the workplace while they're doing an investigation?
Super hard. Yeah, super hard. I mean, I think it's obvious to us when you say, we can't give you the name, but someone here had TB, and everyone automatically who's a contact says, well, who was coughing? And it's hard to prevent that. But all we can do is just say, we can't give you the name, but someone who was working on this floor or in this back room dishwashing area, maybe there's 2 people there, it's really hard, has TB. And it's very, very difficult.
One last question virtually, and then we can go to the audience here. Do we have nurse coordinators who help in coordinating all the care between TB clinic, the public health clinic, and other providers in the city that are taking care of older patients?
Well, I think that we try our best. So you're going to talk to our nurses later. Frankly, our nurses are half nurses and half social workers. So they are the ones who talk most of the families, talk to the PCP, talk to case managers if you're in a SRO or you're in a hotel or you have some type of cognitive disability. So I would say that we try our best. I don't know, Rocio, do you want to add more? Because, we need to go to the expert.
We're a little bit unique than other counties because we also run clinics. So our TB providers are within our reach versus the way other counties are set up. So it's a little bit easier, but we still communicate with specialists and PCPs, and the case managers do it all. They do a lot of different things.
Case managers are the nurses.
Yeah, the nurse case managers, exactly. So
So-
we have nurse case managers that run clinic, case manage, and also do a little bit of social work.
And they have a whole list at their fingertips of things like when we've tried to find, I think little things like Meals on Wheels, but also social services or adult protective services. Sometimes we'll find patients who are older, home alone. We've had one patient where we found him lying on the ground with urine containers all around him, left by his family. It's tough and it's a judgment call. Families trying their best. But maybe it's a time to call for help. But is it always help? It's just very hard. Most older patients, if you ask them, I think would not want to leave their families, even if you find these dangerous situations. It's a very hard call because they think that it's safe rather than going into an unknown like a nursing home or a hospital. So I think these are hard calls that our nurses make.
Yeah. Hi, Janice.
Hi.
You know me, so I feel very lucky to work in the clinic, and it's an amazing team. I had a question about with the refugees from Ukraine and the decision to switch to active or chest X-ray case finding.
Yes.
Since it harkens back to elimination here in the U.S. a long time ago and active case finding in other parts of the world. So just curious from the DPH perspective, how did you make that decision? What data inspired you? How did you get that approved, budgeted? Just curious about that.
You mean from the SF DPH? That's all I have. Yeah. Jurisdiction. I mean, the main thing was it didn't make sense to us to do just IGRA in this perceived risky population. And when we have immigration, we have immigrants who are coming in from China or the Philippines or Central America. The usual process is they get screened overseas by a civil surgeon or overseas panel physician who does all this screening, flags for an abnormal X-ray, also gets sputum. And then when that's cleared, they then enter. So with the parolees, they don't have that same overseas screening. They just are coming. And so we decided we needed to match what happens overseas. When they come here, they get another X-ray by us. We just felt like it made sense for this unscreened population to even more kind of expedite. We need to make sure, but it wasn't like it was a hard decision because we do this for immigrants anyway. It's just that the pathway for these parolees is a little bit expedited and there was missing this X-ray. So that was not hard. And as you know, we're funded by DPH. So I didn't have to make any decision like, oh, where's my budget? Because the city supported this. And so we just send them for X-ray and incorporate it into our regular immigrant screening process.
Thanks, Janice. Really for the work that you and the entire team do, it's clear even hearing from Tay just how much it means to patients to have not just the support, but the human touch that all of you provide. I'm curious a little bit about, sort of beyond San Francisco. I mean, like this San Francisco model, we call it. I mean, it's obviously requires a lot of expert staff. Many people have been doing it for a long time. It's resource heavy and intensive. It's time intensive. To what extent is this model sort of there in other parts of, even just neighboring counties, Alameda, Santa Clara, across California, and outside California? You mentioned the panel might include rural counties, so I'm curious to see how some of these issues are handled there as well. But just from your perspective, I'm trying to understand it. I mean, is this kind of the typical way in which TB is managed in the US, or is San Francisco an outlier in terms of the services it can provide? And then how do outcomes compare in San Francisco relative to other places that may not have these kind of resources?
Yeah, I think Lisa and Jenny can certainly answer as well. I think we are a unique model. We are lucky that the city of San Francisco chose to fund this clinic, I think all the way back in 1980, when there was an initial partnership with Phil and the Curry Center was established and UCSF and DPH got together. There are not a lot of other dedicated TB clinics, to my knowledge, with this specialized nursing. There are a few. I think Sacramento's trying to get there. LA has what they call satellite clinics, but there are not that many clinics, I think, where all TB patients, active TB in a county, must come to that clinic for care. And that's how we develop our expertise, because we see really complicated cases. They're not managed by ID people at Kaiser or somewhere else. They all come to us. And that's how our nurses develop that expertise. But it just kind of has become, it's a confluence of luck and fortunate funding, and people in this city have really been dedicated. I think that's why we're doing things like piloting Study 31, because we have the nursing expertise to capture any adverse events or, so I don't know. I mean, Lisa, please tell me, do you think that maybe New York City might have, Texas maybe with Heartland? I mean, I think there are a few that are highly specialized for TB only.
There are pockets, and there are pockets with high volume and surprisingly no TB clinic, let's say, even in neighboring counties. I think the reality, people think that TB care in the US must be amazing because there's so much amazing work being done by researchers. But the truth is that it's an underfunded piece of public health. And if you look at the accomplishments of Janice and the group at the San Francisco clinic, you have to realize that's in the face of year after year, from 10, 15 years ago, that budget has been slashed. You've had to cut so many positions. There used to be a social worker there, so the nurses could carry the caseload. And with our population specifically, that was the key to cure, because these are people with, life addictions and mental health issues, or really the older population in San Francisco that's getting care is amazing compared to elsewhere. When you have 20-some-year-olds and 30-some-year-olds on treatment, it is so much easier than people on 10 or 20 medications, like you said. But the reality across the US is that a lot of TB care happens in places, public health places, where they now have a new 10%, 20% nurse, and that is their TB coverage. So there is all sorts of science here, but the real access to care and drugs can vary considerably. And it's just kind of an orphan disease here in ways, because it's not on the radar. No matter how much you try to market and go to Congress and do all sorts of things, it's just an old, unsexy disease. A lot of folks. So we need your energy, you guys. You guys that gave the 3-minute pitch, get us the 3-minute pitch to go to Congress with, because people are doing that all the time. But
Jenny, I think Jenny wanted to say something.
I'll just say one thing about this topic and then move on to there are multiple questions virtually. San Francisco has an ideal model, and even San Francisco could use more of an investment and resources, but their outcomes are really influenced, by the investment they have compared to some other counties or other states. A lot of counties that have high morbidity do have categorical clinics. That's what we call a dedicated TB clinic, but most of our counties don't have a dedicated clinic to see TB patients. So they work with the private providers, and it's much more difficult, and it's hard to have great outcomes. Let me move. Yes, Joel.
Thanks, Janice. Can you also say a bit about the services you provide to hospitalized patients that are in private hospitals in Kaiser?
We will in the next section, and we'll allude to it. And then as far as outcomes that Adithya was asking, so once you're on treatment with us, I don't want to brag because I don't want to jinx myself, but the failure and relapse rate right now is close to 0 for us. And I actually think that that's in most of California. So where we're missing is those patients who are presenting late. But we always tell our patients, we know this looks grim, all these pills, all this isolation, everything. But if you can stick with us, we'll get you through it and you won't relapse and you won't fail and you won't die. So, that's the outcomes are hard to compare because no one really is dying once they're on TB treatment, in California at least, but I think it's trying to capture that population that's still elusive for us. Yes, Jenny, did you want to?
Just there's numerous comments, virtually Orange County, Los Angeles, Tulare, many counties do provide dedicated TB services for cases, and particularly, as I mentioned, the higher morbidity like Orange County, San Diego, Los Angeles, Santa Clara have really robust clinic, but there's 62 counties and, many do not. But this is really critical for TB care and outcomes. I would like to turn to the other questions that we have. And one of the questions is, how do you address safety concerns for your staff doing home visits, or is it not a problem?
I think safety as far as violence or safety as far as, we come across crazy situations for sure, but I don't think that they're any different than any community health worker out there who's going into a home. We've had one health worker who was attacked. She said she was attacked by dogs. They were chihuahuas. So I was like, okay. But we took care of it. There are lots of random things that happen. And they're brave souls. They go out there and they do the job. But what's amazing is that sometimes you'll have patients who have never, ever encountered, say, an African-American male. Let's say, I'm just going to give an example. It's an older Chinese gentleman who's lived in Chinatown his whole life, only speaks Chinese. And by the end of that, they're giving him food. They're, preparing meals for him when he arrives in the house. So it's definitely a bond builder in a good way. Our health workers are really amazing in how they build rapport and get the patient to take their medications and kind of get them through it.
Great. Just a related question is, do you have psychologists and social workers in the clinic?
We do not. Our nurses are psychologists and social workers.
You used to have a social worker.
We used to have a part-time social worker, yeah.
Thank you, Janice, and the team for this amazing work here.
Hi, yeah.
One question I had when you were presenting is, how are dots administered to homeless patients who don't have an address?
Right. Rocio, do you want to address that? That's a big box of whatever works.
So basically, we give the patient the choice. So sometimes they want to meet us at a street corner or they come into our clinic. A lot of the times if they have active TB, we're able to house them in our SRO, or not our SRO, but our SRO option. And so they're no longer homeless. But if they decide not to take that housing option, they have an option of deciding for themselves where they want to be dosed.
So we try to give them as much freedom as possible. And some people prefer to not be housed. They have a dog, or there are some limitations to SRO housing. So the incentives definitely help, and whether they use the incentives to go get cigarettes, whatever. We're just happy to get them through TB treatment first priority. If a patient goes missing, then the job of the DCI is to go out and roam around the city, figure out where they're usually hanging out, and they're actually very good at finding them and then bringing them in. So it takes a lot of coaxing.
Good question. Janice, I think the compassion, the passion, the persisting commitment that you, Rocio, the team at the clinic does daily in and out is just awe-inspiring. It's humbling, and I want to echo Adithya's point. You bring a positive light to San Francisco as a TB program, and frankly, models that people look at and are excited to learn from. My question for you is, I had naively, and this is common for me, I have many naive thoughts. I had naively thought that when you got deployed, your whole team got deployed for COVID, and everything was disrupted in the battle against COVID and in responding to the public health emergency, that as that pandemic kind of, simmered away, there would be a heightened awareness and a reinvigoration of the city or the county to invest and bring the resources that have been taken away from you for the last 20 years. So how naively did I think about that? Is there anything there that may come ahead?
That's a bit of a politically loaded question for me.
On purpose. Yes.
I mean, I think, what the audience should know is that TB is an orphan disease, and people who get TB are not voters, and they're not literate often, and they don't speak English, and they don't really have a voice. And so the way politics works in most cities is that if you can speak English and you're comfortable making phone calls and know how to navigate bureaucracy and get to your board of supervisor often, because the board of supervisors is very powerful in San Francisco, that makes a mark. But that's not our population. So I think that that's part of the problem. Is that it? I can't see. Oh, hi.
I'm from Merced County, and
Hi.
the one that's done it for 6 months. We treat all active cases, and on the 30th, the state's going to help us put on an LTBI because the providers said, no, you treat no, you're going to treat the LTBIs. So we're educating our providers all the time. I was surprised when I went to Stanislaus for training with the state and them, they don't treat all the active cases. And we're a very small community compared to them, but they work with the providers, so they provide treatment. So it's interesting to see, those who have more money don't, and those of us who have less money do. So it is very varied. We also make sure our LTBIs are treated. We're in a project with the state of California right now on LTBI and tracking them, but we try and get every single LTBI at least to get treated or know their options for treatment. We've had some that were missed during COVID, and it's like, oh, I can give you your clearance, but did you know that you have LTBI and you should have been offered treatment? Oh, I want my treatment. So we've had 100% who were missed say yes. We've only had, in my 6 months, 3 patients deny taking treatment. And one of them is because his father is MDRO, and so he would have to take a 6-month treatment.
That's amazing. So, thank you.
Oh, one last thing. The homeless, we have a huge homeless in Los Banos. Our local police department help us track them down. And they will assist us and stand out there wherever Johnny is. And, while we're doing our thing, they're there to support. They don't put any muscle. They're just there as a presence. So if somebody felt unsafe, they would have that safety net there.
Thank you for being here. Jenny?
Another question that has arisen virtually is, how do you handle non-compliant patients?
Yeah, there's a lot of those. So it's a lot of, again, I have to give credit to our nurses. It's a lot of coaxing. It's a lot of trying to explain the rationale. Frankly, I use a lot of guilt, and I say, well, you want to see your grandchildren? Do you want to see your family? Do you want to go on vacation? All those things you value in life could be jeopardized if you are smear positive and you hurt your friends and family. But there's lots of different approaches. You have to very much individually tailor it to the patient. Go ahead, Jenny.
One other question. San Francisco mandates all active TB patients to go to your clinic. And so they could not be treated at Kaiser or other private clinics. Just curious how that happens, but applaud the central and expert care.
Yeah, I don't know that we can call it a mandate, because the one thing, though, is that a place like Kaiser does not have the capacity to do directly observed therapy. So often what we'll hear is, well, we'll give the medications, but you do the DOT. And that's not quite how we work, because we need to have the medications in hand to pack them and deliver them. So then I think providers who wish they want to treat for TB realize that there's a lot more than just giving medication. There's DOT, there's the social work, there's making sure isolation is adhered to, there's all the follow-up testing, there's, you know, knowing about adverse events. We have a few partners in the city who we work well with, who understand what we need to do and what they need to do, and that partnership works. So as we're open to working with people to have them treat TB if they're comfortable with it, as long as they understand our challenges logistically. So it's not a mandate, but it's certainly something that is easier for the patient to have kind of a one person delivering the message. But we appreciate that other people want to learn about TB and how to treat it. So, yes.
Janice.
Hi, Mike. I'm looking at Rocio to see if she wants to respond. I mean, you mean like keeping a patient in isolation? Well, so the steps that are sound are that if someone refuses to stay in isolation, so for example, our nurses have seen patients in isolation at Safeway. We're like, okay, you know, or at a movie. So first you approach the patient and you say, so do you understand what isolation is and why it's important? A lot of it is they haven't, you know, it's when you ask the patient, they have real need. They're like, I was hungry and I didn't have any food. I mean, what can you say to that, right? So that addresses then we need to get you food. And so our people have done things like buy pizzas for patients. George was making sandwiches for his patient. I told him to stop doing that because they were really nice sandwiches and it was taking all his time. Instead, go to Safeway and buy a sandwich. So you try to tailor to what is the patient's challenge. Some patients, there are lots of different situations actually. So you just try to meet them halfway as best you can. If someone really is infectious and a risk to public health, so the next steps are they're given a stepwise pattern of legal orders, which are done in conjunction with our city attorney, where it says you are ordered to do this, and it can progress farther. And this is the process in every county. And at some point when a patient says, I'm not doing this, you can have a sheriff go out there and have them hospitalized in an isolation room. You cannot make anyone take treatment legally, but you can isolate them because they're a threat to the public health. And then after a while, they're like, boy, this is a boring isolation room. Limited TV. I've gone through all the Netflix stuff or whatever. And then, you negotiate again. So those cases take a lot of resources, frankly. Maybe we are too paternalistic. I don't know. We're following kind of the standards. And we're hopeful actually that, there's a national committee that's going to look at isolation standards. Are we doing too much? Because it's really terrible for patients, as you've heard. And maybe they're not infectious. Maybe we can stop earlier. And maybe if you've been on 14 days and some data says like a few days, you're not infectious, but it's old data. And so we try to follow CDC's mandate, but there are a lot of individual exceptions that we make just so patients can survive and live their lives. So
I'd like to add a few words to that. I mean, I can see where it can be viewed as paternalistic and also invasion on a patient's rights. And, we've had conversation with patients, but on the other hand, we're public health. So our mandate's to make sure we protect the public. So I asked the patient, do you know where you got your TB? No. Who gave, how did you end up getting TB? Is by someone who didn't observe isolation, maybe, or somebody who didn't know they were sick with active infectious TB. So I get them to think of the other side of the coin and really, view that other perspective. I mean, we're a very individualistic society, but we also have to think about our community, and taking care of our community is very important.
Yeah, we get a lot of responses. I was telling Lisa, some patients like, I moved from China to not be in a communist state. And now you are making me take pills and stay in isolation. This is a police state. We get a lot thrown at us. So you have to be very flexible and just always understanding. And like, we understand, but we're going to cure you. So hang in with us.
Okay, I'm just going to jump in. I know we have more questions, but because we have put the entire afternoon on Janice's shoulder, we do want to give her a break before her next session. So we're going to move into a break. We'll rejoin here. We'll start again at 3:05. And I think based on how exciting this conversation is, you'll really enjoy being able to celebrate and highlight the work of TB nurses and ask them questions about their. Yes.
Can I make one plea to this research community? I've already given it to Payam. So, you know, a lot of research and clinical trials are by necessity overseas, typically in a younger population. Our patients are 65 and older. So it's very hard, and I don't know how we bridge this gap to take, let's say, study 31, which was the median age was 31 years, and then apply it to a population that's in their 80s or 90s. And I don't know, you know, I just feel like there needs to be more addressing of this gap and how we can apply what's happening overseas to here, because we have a lot of issues. I mean, one time I was talking to Adithya and he's like, well, just use bedaquiline. And I'm like, okay, bedaquiline is great if you're 30, but not if you're 90 or 80 and you have atrial fibrillation and you can't, you know, follow your cardiac issues. And so this is kind of, I hope, shows some of you that we need help here too. Our patients hate our treatment. They think it sucks. We'd also like to see treatment shortening regimens applied, you know, in the US. It would benefit our right next door. So thank you.
All right. End of the day. How are we feeling? Great. Energized. Well, I think for our next session, I think the last session really brings it together in that when we think about TB and the successes that we've had and everyone in this room, it's really the people that are passionate and really bringing the care to the people. So with that, I don't know how much introduction I need to continue to give to Janice, who's really been our MC, but you know, I will just say she's clearly our unsung hero in many ways, and medical director.
Fortunately, I'm not really the focus of this last session. So let's see. We're going to focus on nursing and unsung heroes. They definitely fit that bill. So actually, I'm going to start with outside of San Francisco. So one of the other things that we do is we co-manage patients who are hospitalized in San Francisco. And because San Francisco has several tertiary care centers and a large academic center where many referrals come in, a lot of really complicated and sick TB patients are hospitalized in San Francisco, and many of them from Northern California. And so when a patient arrives at a hospital, we are notified and we help care for that patient, and they're really sick. These are the patients that are going to die. So between 2020 and 2022, there were 107 hospitalized TB cases in San Francisco, and a third about were from other outlying counties. And so we have one partner. They're all our partners, and we all work together. But I asked our partners in Humboldt County if they would be willing to be interviewed for this session, because what was really apparent to me after working with them is how much more work they do than we do with lesser resources. So I'm going to describe a case. And by the end, I actually said this in the interview. I'm like, I don't know, why do people live in Humboldt County? But I put this up because it's beautiful. That's why. And it's a lifestyle and it's gorgeous. It's lovely. But you will hear about the struggles they face in this video. So our shared case was a man in his 50s who was US born. He had never traveled. He was healthy. He had no risk factors for TB. So you can already see why were they flummoxed about what he had. He went to the ER multiple times. He had complaints of weight loss, leg swelling, and fainting. Those are not all classic TB symptoms. And then he ended up at SF General Hospital because of his medical complexity. And he was ultimately diagnosed with disseminated TB of many, many organs. So pulmonary, eye, liver, spleen, adrenals, peritoneum, intestines, and prostate. That's pretty much your whole body. He also was diagnosed with cirrhosis. He was started on TB treatment. He had multiple complications, including a lung clot, renal failure, drug reaction, worsening nodules thought to be a reaction to his TB meds requiring steroids. So he was actually hospitalized at the General for 4.5 months before he traveled back to Humboldt County to his home. And I wanted to share with you the interview with the health officers and public health nurse there, so you could hear their perspective on how they manage TB in a frankly, less resource county for TB care.
I have with me Candy and Erica was the primary public health nurse who was receiving this patient. And so if it's okay, Erica, I'd like to ask you a couple of questions about, you knew this patient when he came over and you knew you were getting him back to help with his care. So initially, what were the challenges that you thought about in getting this patient back home to Humboldt County from SFGH? Because he was quite complex. And I recall he was so weak. We weren't even sure he could make the taxi ride or car ride back, just because it was going to be a long, uncomfortable journey for him. So would you mind helping the audience understand the challenges with how to take care of this complex patient in your county?
I think Dr. Stockton was going to give a bit of an overview about just what some of the general challenges are just with receiving a patient in general in Humboldt County, if that's okay.
That would be great. We want to hear.
So I'll talk just a little bit about the general medical situation. So Humboldt County is a rural county, only approximately 135,000 people spread over a little more than 4,000 square miles. So it's a large area. It's a lot of people living in remote rural communities in the mountains or back in the valley area that are distant from any of the areas that have medical care in them. So we have a severe shortage of primary care medical providers locally. So a typical patient like this who was not receiving medical care from a primary care provider prior to him being diagnosed with this illness may have to wait anywhere from 3 to 12 months to actually be able to establish with a new primary care provider.
Wow.
And it may not be one that, is practicing within an hour of where they live, which if you can imagine, if you're not able to drive yourself and if you're needing medical transport to appointments, how difficult that would be, especially because this was in the early stages of the pandemic prior to the time when everybody was really converting over to telemedicine, which helps a little, but in a lot of these rural areas, there is no access or no reliable access to internet or Wi-Fi. So having the ability to do telemedicine appointments, while it's helped a segment of our population, doesn't actually reach our most remote citizens. So I mean, that's just kind of the most basic, is just the physical problems with getting transported back up here, being able to find a doctor or primary care provider who's able to coordinate all of the care that somebody like this would need. And then you add in things like access to medications. There may be no pharmacy within an hour or two of the area at which you live, and a lot of our rural residents can't receive mail delivery directly at their property, so they have to travel into a post office box or someplace else to get deliveries, and not all mail order companies and pharmacies will deliver to post office boxes. So there's a lot of logistical difficulties just in caring for anybody who's chronically ill to begin with. And then you add in our really small county size, which means that we don't have a lot of specialty services locally. It takes a certain amount of population to support any given kind of specialist. We have one infectious disease doctor in the county. So there's that lack of access to the specialty services that are needed to coordinate, and just a really difficult situation to be in. And then we may go 2 or 3 or 4 or even 5 years between having a case of active tuberculosis in the county. So being able to keep our skill set up to be able to manage the patients when they do occur is really difficult. Most of our primary care doctors in Humboldt County have never worked with a case of tuberculosis. And actually on any given day, most of our health department has never worked with a case of tuberculosis. So it's a unique situation, definitely.
So what you're saying sounds really, really challenging, just knowing that our typical TB patients are taking 10, 12, 14 pills a day. We need to regularly draw their blood, check in on how they're doing, watch out for side effects, do things like get regular eye exams, take a look at, whether there's a rash or not, check their liver function tests, look for any problems with neuropathy. So many things to track with TB. And it sounds like you even just had a hard time just getting a regular doctor for this patient and insurance because he hadn't had established care before.
Right. And in many of the rural areas, there isn't actually home health services available to send out for those things. And actually, the county itself doesn't have any commercial laboratories. So our laboratories are all associated with either the hospital or the clinic that they're based out of, which means like just, sending him to an outpatient lab isn't even a possibility.
Right. This sounds really hard. And this patient I don't think he was able to drive himself. He was not mobile. So all of this needed to be figured out. The moment you heard he's coming, which the hospital has its own challenges of trying to get discharges moving because they, were at capacity because of COVID. So lots of different competing challenges with everybody. So in this patient who had disseminated TB and needed to have daily TB meds and monitoring, how did you perform the directly observed therapy and how did it go? And how did monitoring go for him?
I think in some ways, I don't think we differ from other programs. Home visits are performed initially for DOT. We do med box bills and then a patient assessments by a public health nurse. We typically assess the patient for a short period of time to determine if they're a candidate for video DOT. And then we convert from DOT visits to video DOT visits after we determine that patient, meets the requirements for that, if they're stable enough that they can meet those requirements. Unfortunately, for this particular individual, for a variety of reasons, they did not meet those requirements for the first 5 months of treatment. So they were home visits 5 days per week for the first 5 months of treatment, except the time periods when they were, of those 5 months when they were at the hospital. Where we do differ significantly is that the distance we may have to travel to reach our patients. One TB visit may require 2 to 4 hours one-way travel to arrive at the patient home. So it can take an entire workday just to do one home visit. So it's not really reasonable for us to do daily DOT visits. We would have a staff member spending their entire week doing just DOT visits if we did that. We coordinate when we do that to maximize that visit. We assess the patient, deliver supplies and incentives. We obtain signatures on the forms when we go out. Continue our in-person contact investigation while we're out in that area. And then we greet local healthcare providers in that area and the labs to provide education and information when possible. So when you do make that trip, you get as much done as possible. You do a lot of planning prior to just even your first DOT visit to see a patient in a remote area.
And I can imagine, Erica, this patient did not live with anyone else, if I'm remembering right. So you really had to do everything you could to get everything you could out of him. How are you doing? Are you able to go to the bathroom? Are you able to feed yourself? How are you getting food? Because he was, on his own. So not only are you doing a lot of TB care, you're doing a lot of social work, actually.
Yeah.
in this, quick hit that you have, this short time that you have to make sure the patient's doing well globally, not just from a TB standpoint, because he also had a cirrhosis to manage. He had, a lot of other chronic problems that came up as a result of being hospitalized here and his TB diagnosis.
I think that's one of the things that you pick up when you do a home visit. That's one of the advantages to a home visit is you sometimes don't have to ask questions, because if you've been at a home visit repeatedly, you can look around and you can note differences. You can note whether the home is tidy, what wrappers are laying on the ground, it's a trash can been empty, little things that you can pick up on.
Alcohol bottles or something, if the patient's a drinker.
You're able to assess the environment and as well as the patient without even having to ask questions.
And you also had to spend, I recall, or nurses spend some time also talking to family members to kind of keep them in the loop on how patient might be doing or whether they need support or what support's available, how far away they live. Who's taking care of his pets, things like that. Because he had some pets he was worried about while he was hospitalized for so long.
Yeah, one of the questions you had asked in it was about, what did we do as the patient deteriorated? And because we weren't able to establish with consistent case management because of just the issues in general with inconsistencies in healthcare. So we as public health kind of became the de facto case management.
Yeah.
Patient.
Were you eventually able to find a primary care doctor for this patient locally?
The provider, the patient did have a primary care provider established, and he still does have a primary care provider, a consistent primary care provider, but that's not the same as a case manager who would make sure that follow up to make sure that all of the forms are completed for transportation, that any assistance with disability forms are completed, that social security, permanent social security forms are completed, that applications for Medi-Cal are completed, applications for a parking placard are completed.
Yeah.
Coordinating with home health to make sure that they come on time if they're available. All of those case management things that the patient needs, but that don't fall under tuberculosis and don't fall under primary care. The patient really needed that kind of case management.
Yeah, things that are just really important that most people take for granted. But I remember this patient, for example, he didn't have. I don't recall that he had a bank account. He had a hard time finding a way to pay his bills, even though he had money, just kind of getting that process going because he didn't have anything electronically set up. And so that kind of fell on his shoulders, but because he was not quite, I think, ready to take on all that, also the case manager's shoulders.
I think a lot of times like we were talking about in rural communities, is that when you don't have high-speed internet access, people don't often, you can't count on technology. You don't set up electronic bank accounts. You don't set up, to do e-banking. Everything is done, in person. It's really important to have those brick and mortar facilities for those reasons. And we have those same challenges like with video.dot. I often have difficulty determining if a patient has really not performed video.dot for a week, or if they simply haven't left their remote location to go to the store or anything, where, if in their remote location, they may not have cell phone reception. So we have to wait until they have a reason to leave their home, to go to the post office or something else where they would get cell reception, and all of those videos would upload and send to us.
Wow. These are things we take for granted here. We're not going to, every time we talk to rural partners, we never complain after about what we do. Candy, did you want to add something?
I was going to say actually that, how appreciative we are of the collaboration between the expert consultation that you guys provided and the infectious disease component of that care. But how I really do want to call out that Erica just kind of breezed over the fact that, yeah, he got a primary care provider, but our public health nurses who served as, Erica and the nurses who served as the champions for this patient, when we say, oh yeah, he got a primary care provider, what that actually entailed was Erica and her colleagues getting on the phone and calling everybody they knew at surrounding clinics and trying to sweet talk somebody into agreeing to see this patient.
Into taking him, right?
Yeah, so I mean, it almost sounds like that just magically, oh, of course there was a doctor, but even that required a significant investment of time.
Work, right?
Just to find somebody who would be able to see him and do that. And we are so fortunate that we have such dedicated public health nurses working with our patients.
And then how did he get to appointments? Did you have to drive him, or how did he arrange? How did he get his labs drawn? How did he get to the doctor? These are all things we take for granted here, but I want to hear how that's done in your county.
Transportation in general is a problem in rural areas. It was a big shock for me when I moved to California. Bus lines, I was surprised to learn, they may run. The closest bus stop could be 7 to 90 miles from your home. So there is a bus that runs to the town, but you still have to find a way to get to that bus stop So consider that a round trip drive just to get to the bus stop could be $45 in fuel costs.
Wow.
Because, in order to get through mountainous areas, you have to have a four-wheel drive vehicle or an all-wheel drive vehicle. Those average about 18 to 22 miles a gallon in fuel efficiency. And, you have to go 90 miles one way to get to the bus stop. And then you still have to pay the bus fare and all of that time sitting on a bus just to get to town to go to an appointment. There's no Uber, there's no Lyft, there's no taxi. And if there is that option available, it's going to be equally cost prohibitive. A full round trip drive, if you have access to a vehicle, a good reliable vehicle that can go that far, imagine that's going to cost $100 in fuel costs just for one visit to the coast. That's what we refer to.
So how did this patient manage to get to and from doctor's appointments and lab draws, and also sputum? How did you get sputum out of him? How did all these TB, metrics? How did you get those accomplished?
It was a hodgepodge. Sometimes walking together, sometimes transportation had been arranged when there had been a case manager, an appointment had been scheduled, and transportation had also been scheduled through the insurance company. Sometimes appointments were missed because an appointment had been scheduled, but transportation had not been scheduled. So the patient would be standing outside of their home waiting for the ride that never came, and then ultimately would have to call and let them know that the provider's office know that transportation had never arrived.
It just sounds like
blood
it was.
Draws. One time the patient needed a critical blood draw, and I believe the PCP went to the patient home and drew the blood.
Okay. Wow. And then, as you, I think, alluded to, this patient did start to have some adverse events to some of his TB medications. And that's the same challenge we have here in San Francisco. We find that about a third of our patients have some adverse events. And so that sounds like, with all the challenges you're already having, how do you assess those and how do you get those, looked at by a specialist? Or that also sounds challenging, but then you're kind of more of a, you need to have it looked at pretty quickly as best you can.
We called you a lot.
Happy to help, but I'm still not there. I don't have my car up there.
On multiple occasions, we did DOT daily. So that was the main reason that we were doing in-person DOT Monday through Friday still, was because there were so many complications and the patient situation. And we do that as often as we can, as often as we have staff available, and as patient need requires. And also
go ahead.
To account for, to still allow patient privacy too.
Yeah.
You want to go to video dot as quickly as possible. But in this particular instance, there were 3 occasions when we arrived and had to call an ambulance. In one instance, the patient experienced anemia and the hemoglobin was measured at the hospital. It was below 5. Another time, I arrived and the patient had been experiencing gradual vision loss over the weekend from a thiamutol toxicity. And another time, there was just gradual, well, actually not gradual, but rapid decline with inability to ambulate. And in that instance, I did end up speaking with the patient and calling the patient's family from out of the area to come to assist the patient, and eventually did call and try to get placement in the hospital.
Yeah. Yeah. And I mean, I know Candy was describing how there are not that many tertiary facilities in your county. So it sounds like the hospitals and ERs that the patient was seen at were trying their best, but it's just very challenging when you have this level of complexity in a patient and these, really scary side effects that you just hear about them. You're like, oh, what are we going to do? I can imagine. It's really
And
heroic.
being in a county where we rarely see TB cases, so this isn't something, you know, that our ER docs may have seen. They may not recognize the potential for it being a complication of tuberculosis treatment because he had so many other concurrent health issues.
Yeah.
And I mean, I think this is no shock to anybody, but an emergency room is not the best place to get coordinated care. Their job is really to decide, are you going to die right this minute or not? If not, then they send you home to sort it out with your medical team. And that's really problematic, you know, for a patient like this who has, you know, who just doesn't have access to the treatment that he needs to figure that out. And it doesn't help that this was occurring in the middle of our COVID surge locally when our hospitals were barely managing to stay staffed and functioning as it was. And so it just, I mean, added a whole nother layer of complexity to what would have already been a really difficult case.
Yeah. Yeah. I have to mention this was a global effort because he was also followed by a UCSF ID doc. So it wasn't just you, it was all of your collective ERs and hospitals and public health nurses and primary care people and local specialists. Your department, Candy, we helped a little bit. The state department helped a little bit, state TV branch. There was a UCSF provider involved. So it really was a global effort, even though all of us were watching from afar.
And it wasn't just a little bit. We needed to be the hands and feet on the ground to make the contact here, but we would have been completely lost without the support that we got from you and from the state. That we do not have the skill set necessary to provide the care the patient needed. We have some level of manpower, we have a lot of passion, we have a lot of dedication to our work, but we could not have provided the care this patient needed without the assistance that we got from you guys and from the state.
Yeah, and so I think to wrap up what happened with this patient, he ended up back at the General Hospital in San Francisco. His medications were adjusted, and any concerns we had or you had as far as his anemia and his vision were all looked into. So he got the whole overhaul, you know, in the body shop. And then he went back to your county, and then I think was on treatment for another year. So he actually was your patient for at least a year and a half, which is a long time to be on TB medications, a long time to do daily DOT, and a long time to kind of worry and manage the side effects along with all of his other issues, social issues, and getting, you know, transportation issues, everything. So Erica, I know he was your first TB case, actually. So looking back, what would you like the audience to know about your work? And Candy, feel free to chime in, because from our eyes, with what you've done, it was amazing. So, you know, just the audience that you're talking to is mostly lay people or lab people or researchers. And so they really want to hear what it is on the ground as far as how we're actually taking care of these patients and, you know, just everything that we do. That's what World TB Day is about. So when you think about him, Erica, like what relief he's.
I think the hardest thing was setting boundaries. It was so difficult to say no sometimes, to see a patient with so much need, and it continues to be that with all patients. You know, when you have a county where there's so many patients with so many needs and there are so many voids, it's tempting to fill that void. And it actually takes a lot less time to do something for a patient than to try to find a solution. It would have taken me less time to do some of the things I did than it did to think of, let's call the family, let's get the family to come down here to help out now. And then it I can't verbalize, but just to say that when you have to say no, it's even harder than it is to just do things for patients.
Yeah, you're a nurse, so you want to do everything, right? Candy, do you want to add anything?
I will just add that this was actually also my first TB patient. I'm new in this role, and so I'm well versed in how difficult it is to take care of patients with chronic illnesses in rural areas. I've been doing this for 25 years. Like, that piece wasn't new, but I I honestly was blown away by the level of support that's available to us. That was kind of one of the scariest things for me when I walked into this job on the first day and we're like, oh, by the way, you've got this. And I'm like, I don't know about this. My whole career, I've never, I treated like 2 cases of latent TB before this. And so I will say that I am just really impressed by how much support is available to us smaller rural communities when we're faced with these kinds of problems. And also a little sad, I think, that we as rural communities don't do a better job actually educating each other about the support that's available, because I think we don't always know that help exists or how to reach out to. So we're very fortunate, you know, that we came to this patient in combination through you after he'd been diagnosed in San Francisco, so that we got plugged into that support network immediately. And to anybody else in rural communities who are struggling with this, like, reach out and ask, because there is a lot of help out there, and it was invaluable for us.
Well, the partnership continues, and we learned a lot from you as well, because he was also a puzzle when he got here, and many world famous ID people were puzzled by this patient and why he was so sick. He didn't have any TB risk factors. You know, he was just someone living his life, and then he ended up with this horrible, complicated disease, and a lot of people puzzled over him. So I think he was a learning opportunity for you, for us, for UCSF, for SFGH, for everybody, but he actually was such a lovely person that, of course, we all wanted to come together to help. So I think, you know, I know both of you now pretty well, so I'm not going to be great at asking questions that are, you know, probing or deep, but I think you've explained what you've gone through. And again, I wish we had a picture of where you are, so that, you know, I'm sure people in the city are kind of like, well, why would you work there? But it's so beautiful. But I think that's why this patient wanted to go home, because, you know, it's a beautiful place to live too. And it's a great community. So thank you for giving us a picture into what it's like into rural TB healthcare, and forever you'll be my hero. So thank you for your time. Do you have any last thoughts that you want to share?
I do. I did want to add how critical it is to have the support system, the support network. I know that when I initially got the case, the first thoughts that went through my mind was, I don't remember anything about TB. And I reviewed my notes, and then after reviewing my notes, my first call was to our CDPH TB control branch liaison. And I called Leslie Henry, and my notes say, is there a checklist? And she gave me a rough checklist to follow that was super helpful. And then the next calls were in the checklist were to contact the nurses and the public health branch that has the actual patient. And I was able to speak with your team there in San Francisco. And I talked with Anna Lee and with Felix, and we've been collaborators ever since on many cases since that time. Thank you very much for your support and for all of your guidance.
I wanted you on, not for you to thank us, but to like
I know, but
have you represent what, you know, is a great part of rural healthcare, is the dedication.
But people need to know that it's okay to ask questions. It's okay to say, I felt like I should have known the answers. Like, I had been to all of these trainings at the Curry Center, and part of me was too proud at first to say, I don't know. And I wanted to find the answers in the book, but I needed to get those answers more quickly, and to be able to just say, hey, wait a second, what am I supposed to do? What forms am I supposed to ask? It's okay to just ask another colleague. I don't remember. I know that I've been through this training before. What am I supposed to do again? Can you refresh my memory? It's okay to ask. It's okay to not know.
Especially once every 5 years, you have to have that refresher, right? Okay, well, thank you so much for both of you to participate and share your experiences with the community on World TB Day. I really appreciate working with you. So thank you.
Bye.
Bye-bye.
So heroic. So with that case in Humboldt, Annalise in the audience, Penn and Barry's here. He was the CDPH expert who also helped this really hard patient. Thank you to both. Okay, I'm going to bring it home. We're going to talk about one more patient. And again, this is just to show, the nurses are the heroes in all of this and what they do. So this is a 20-ish-year-old male from Central America. He's an asylum seeker. He reported for the required TB screening that we've already talked about. He had an X-ray that showed multiple nodules and cavities. He had numerous AFB smear positive. He actually was started on a 4-month HPMZ regimen the next day, hospitalized for isolation, smear converted to negative within 1 week. We are finding, Payam, that regimen is very good at getting people out of isolation quickly. And then he was able to be discharged. So while he's still with us, nursing was able to call him every day during the weekends to make sure he didn't have any side effects. We put him immediately on VDOT so he could return to his sponsor's house or home in another county. We collected donations of clothing, shoes, soap, household items. That's a picture of all the donations, many from UCSF colleagues. And Rocio brought him Coke because he had a sweet tooth, candy, and she made him home-cooked meals that were reminiscent of his home country. And we were also able to connect him with the Office of Refugee Health and Legal Services to start the process for obtaining asylum. So these are just some non-TB tasks that I have seen our nurses do in the last 60 days. Educate patients' families and hear concerns. That's their normal job. Check in on challenges like housing, food, home care, transportation, many things. They perform home visits before and after clinics, so they have checked out. And on their way home, they will go and check on a patient or draw blood. Provide support for patients entering end-of-life care, so they'll call a hospice nurse. They will work with palliative care. They will alert APS if there are potential harmful situations. They will help complete insurance and other paperwork for our patients. I've seen that. They'll make dentist appointments for our patients. They'll find a dentist who will take Medi-Cal, it's called Denti-Cal, and then they will get that patient there by driving them themselves. They will prepare home-cooked meals. They'll bring in their own clothing. They'll buy special incentives like chocolate bars, oil of Olay, Rocio has bought for a patient. I've seen a nurse try to teach another patient English because she was frustrated because he wasn't trying and he only spoke Chinese. And we have many, many patients, surprisingly, who don't want to be hospitalized or be CMIS because they want to stay with their dogs. And Rocio has found a way to find shelter for dogs while a patient is hospitalized. So with that, I'm going to turn it over to Devin to interview our nurses that are up here today. Some were too shy to come up, but we have George, we have Rocio, and we have Allie.
I guess on behalf of everyone, I just want to thank you. I mean, let's give them another round of applause. Really amazing to see everything that you do for the care of these individuals. And I have some questions just to kind of start us, but of course, if there are other questions the audience has or virtual, please let me know. So I've heard you be referred to as the primary provider, the nurse, the case manager, social worker, psychologist, many more, dental appointment provider. How would you define your role, and what are some of the barriers that maybe prevent you from doing that role?
Hi, everyone. That's a good question. I think quickly it's all of the above to your question. We do see a lot of barriers, not just with housing or food insecurities, or stigma in some of our patients' families. I think taking a lot of time to have active listening for your patients, to all their concerns, whether it's TB related or whether they just want to have someone to talk to. I think Janice mentioned, like, sometimes they don't have a family member to talk to because of the stigma. So, as nurses, sometimes we're like the only outlet for them. I guess other other barriers. I mean, there's so many. There's transportation, like we mentioned. You know, we do what we can to transport our patients to and from clinic, and you know, as you know, SF parking is horrible. You know, out of the day, you might only be able to park 2 hours. So we try to at least help them in that area. I mean, we also provide a lot of incentives, Target, Safeway, and at times we would go out to Safeway, buy food, whatever they want. We make sandwiches, even though Janice told me not to. But you know, it sometimes that's the highlight of a patient's day. You know, they look forward to the food, they look forward to seeing us, and you know, it's just the little things that matter, and you just have to listen, I think, and hear the concerns and try to address them as best as you can.
Great. If there's any other questions, again, feel free to raise your hand. But with all that you have to do, I guess, on one level, what got you into the TB world, and I guess more importantly, you know, what's keeping you in this space?
Well, I landed just like some other people said this morning in the TB world by accident. And I actually, my first job in TB was with the state TB control branch. And I remember my, you know, graduating from college and my college roommates all like, oh, the state's hiring, you should apply. You know, we're graduating. And so I ended up applying for a random job with the state, and it ended up being with the state TB control branch. And I worked there for many years. And then I decided that I did a lot of different things at the branch. I worked on research, outbreak response, the registry, just wherever help was needed. I'm like, hey, my research project is, you know, slow right now. Let me help. And so, so I worked the back end of TB for a while, and then I got to visit a lot of counties, and I'm all like, really like what the public health nurses are doing. They really get, you know, their hands dirty. You know, well, you know, they really get in there, and you know, they're out there in the field, and it was really exciting from the research perspective that I was, you know, collecting epi data and all this stuff, and I'm all like, they're really out there making a, you know, a huge difference. So decided to go back to school and become a nurse, and worked in the nursing world for a little bit, and then, you know, once you're in the TB world, people draw you back. You know, they're like, hey, Rocio, you might want, you know, there's a job here. And so I ended up coming back to TB as a public health nurse, and I've been doing this for 15 years, and with a couple of different counties. And I think what keeps me doing TB is because every single patient is different. It's the same disease, but it's never the same case. It's always a new challenge with every single patient. It's like it keeps your mind active. Like, what are you going to do with this patient to, you know, help them, convince them, address their fears, address their questions? And so I feel like I'm always on my toes, sort of thing, to think of what else, how am I gonna, you know, think outside the box. Janice, it reminds me of something Janice and I had a challenge we had earlier this week with a referral we got in the patient had to be induced, but she's all like, I can't stick anything big in my mouth. And so we had to demonstrate, you know, hey, this is, you know, so I mean, I had never had that happen to me in 15 years, but it was, you know, and she was, you know, she was very afraid. It was her fear. So we had to address her fears that, you know, it wasn't going to hurt her, and, you know, that sort of thing. So I find it interesting, and I find it helping individual patients very rewarding. And my colleagues, they're wonderful too. They're wonderful people that I work with, you know, and they're always willing to help. And so that's really important, to have colleagues who are always willing to help and are, you know, what can I do? And they're willing to stretch, you know, to work at the edge of their practice is really important. You want to add anything?
what Rocio didn't say was that she put the sputum induction kit in her own mouth and like showed the patient what was going to happen so that the patient was ultimately okay. She used a clean one for the patient, but it's great. I think that's something that keeps me in TB care is like this fantastic team and how like they go above and beyond every day. And also like there's so many people in the audience that I know, and it's so exciting. Like I get on phone calls with Joel Ernst sometimes, and we talk about TB, and we talk to Lisa Chen on Friday radiology conference, and Janice is such a fantastic mentor. And so I think we have this wonderful community in San Francisco. And so that's what keeps me in TB work. And of course, you know, my colleagues here. So.
Anything extra, George?
And yeah, just to echo Rocio, you know, what keeps me with TB is just the colleagues that I work with, the fact that we can vent to each other, and you know, we always have each other's backs. And you know, when patients don't do a certain thing, we go to each other for help. So there's always someone that we can always ask for help. And you know, we really do care about what we do. And I think all of us nurses in our clinic, not just nurses, but physicians and health workers and DCIs, you know, we all actually care about what we do. And, you know, when, you know, I have an instance where like, you know, we had a patient that, you know, passed a few years ago unexpectedly. And, you know, it's really hard, you know, on all of us because we get to know them so well, and, you know, we have each other to lean on. So I think having that support system is really important. Then, yeah.
Wonderful. I think, as you know, this is a broad audience of people that may not really have the direct care of patients like you do. So, you know, are there aspects of the work that you do that you would want us to really know that goes into taking care of any of these individuals?
I think one of the things that isn't always obvious in TB care is the time. And I think Janice has done a good job of kind of outlining some of that. But for example, we've had a patient on a multi-drug resistant regimen recently. And in order to get that regimen to our clinic, in order to give to this patient, it just took many phone calls. It took, I was filling out random forms online that I'd never filled out before with Rocio over my shoulder, helping me do this. At one point, Rocio was storming down 24th to Walgreens to talk to the manager in order to get this medication ordered. And so it's really challenging. And even though, you know, we are compared to like Humboldt County, and just hearing their story and how above and beyond they go, we still do have a lot of resource challenges. Or, you know, there's a rifapentine shortage right now. And so, you know, we're limited in who we can give these new short course regimens to, who would really benefit from it for a number of reasons. And so, yeah, I just wish people could understand that, and hope that that's a call to all these wonderful researchers out in the audience that like, we need research here, we need funds here, we need access to medications here.
Oh, great. Please.
Thank you. We've got some great questions from our online audience here. So the first one, someone asked, when you're talking about buying and preparing food for patients, are you purchasing the items with your own money, or do you have funding for those types of things to assist your patients?
Both. You know, we do sign out gift cards for patients, and sometimes we would sign them out, you know, for that patient, and then sometimes we would use money out of our own pockets too, for the patient, because the gift cards we have are only limited to certain stores, and you know, sometimes patients would prefer other certain things.
Sure, please.
Great, thank you. Another question is, do you handle other public health programs aside from TB, and normally what kind of caseload do you have per month?
We only do TB, and we, depending on who's out, we've had a couple of nurses out. So we handle each nurse is handling about 10 to 12 cases. And that's not counting discharges because we also manage discharges. So yeah. And these are only active cases. We also have very special LTBI patients that we also case manage that aren't in that count. So we have a couple of patients that come into clinic that need some special TLC, I call it. And so the nurses take extra time to make sure the patients get there. And so those aren't really case managed really, but there's some aspect of case management that goes into their care.
Oh, sure. Go for it. Go for it.
I could keep going, but I
Yeah.
want
No,
the room to have a chance to.
Everyone in the room.
Someone else asked, how do you work with preteen and teenage cases in encouraging compliance, especially if you're unable to provide incentives?
We had a recent teen case about last year. I didn't case manage them. The actually case manager isn't here. We offered incentives, but it was a lot of calls. She ended up, or they ended up being on a VDOT. So, and the videos were done very late at night. So, so there were a lot of phone calls, and with the nurse manager took a lot of time working with that patient. But she was very independent, and they worked with the family and so forth. So we haven't, our patients are on the older spectrum. But when we do get teenage cases and preteens, I mean, there are a lot of, we have to kind of shift our thinking and approach. I think our most difficult cases are our pediatric cases or our toddler cases, because you're going through the terrible tooth and no one wants to take medicine. So, I mean, do you want to hold a child down? We don't, and we don't want to get to that extreme, but a lot of times we end up doing that. So it's very difficult. So we do a lot of, we offer a lot of, we have a lot of foods to offer, a lot of distractions, and it's a lot of work. It can take up to 2 hours for that first dosing, where we bring different foods, where we're chasing the child down, where we're offering toys, where we're playing videos. What else do we do, George? We do dance. Yes, we dance also. Baby Shark. Yeah, that's what we play. Anything else, George?
I mean, I think, on top of all this, we do have to put ourselves in the perspective of the parent as well, and know that, they don't want to see their child sick. So just kind of understanding where they're coming from, being respectful, and, if there's a concern, maybe they're not addressing it. So, I usually just ask the parents, like, what is the barrier? What is the issue? How can we help? How can we make things better? And, it's an open-ended conversation.
Yeah, it's so important. I think highlighting that while we think of the individual that has TB, they're obviously within a family and household, and their care is a reflection of how we can partner with the rest of the household. I think there was a question from Anthony.
So I want to thank y'all, of course, to have the perseverance, hard work, and compassion to take care of all these TB patients. And my question has to do with TB awareness. Back in undergrad, 5 years ago for me, I used to volunteer at student-run clinics, and I went to UC Davis for undergrads. I also volunteered at the UC Davis hospital, and everyone had to do a TST skin test. And I thought, wow, this is a dumb test. Because being very naive and ignorant about TB, I really thought it was a boomer disease. I'm never going to get this ever. And so why do I need this skin test? And it wasn't until I joined a TB lab at UCSF where, I learned the biology of TB, but I think most importantly, just the prevalence of it. Never knew it was a pandemic, an ongoing pandemic. Never knew that it was very a costly disease, and that the only vaccine that we have, I guess approved vaccine that we have is BCG that's 100 years old. And I thought wow, this is really, really crazy. I'm telling this to all of my friends who are in med school, nursing school, and they're also the same reaction as me. TB is relevant. And I was like, oh my God, this is horrible. And so my question goes, and I kind of, I guess, blame it on my generation a little bit for being a little too ignorant, is what do you think is the best way and best approach to bring more TB awareness towards the younger generation who are not obviously affected by TB, unlike the older generation?
I can answer that because first of all, go Aggies, yay.
Hey, go Aggies.
Yeah, all right. Well, I have kids in their 20s and I made sure they knew about TB because I worked in TV. So I made them read Ticking Time Bomb like in 6th grade. I think it should be required reading in the schools. But that's me, that's my preference. But I think that because this disease is looked at as archaic and it's never gonna, hit me. I think more people your age should be involved with research and care. And it is, it's dwindling and, but I think with what's happened with COVID, and this is my theory, there might be a slight resurgence in the US, maybe in California, because I think there's a lot of TB that wasn't diagnosed while we were all in isolation, or during COVID. But I think campaigns, awareness, making sure you tell your friends, word of mouth, is the best way to do it.
Yeah, and I think as TB Clinic, that's one of our missions is to help educate. We work with the Curry Center and help educate other providers, physicians, medical students, nurses, nurse practitioners, and to show that TB is alive and unwell here in California, especially and in San Francisco. And so we try to partner a lot with different clinics and groups, and we do a lot of training, and we're available to do training. And we love to talk about TB, and so I think that's how we're starting, is that we're just trying to get out and talk to people about TB. So I heard themes today of that treatment sucks and DOT is not much better. So how do you approach your patients when you first are explaining to them that this process is going to occur for at least 4 to 6 months, if not longer? And how do you build a partnership with your patient?
Their first visits to the clinic are usually pretty long. But I think we take a lot of time to provide as much and appropriate education as possible for the patient, but to not overwhelm them so much because they're dealing with, knowing they have to be observed for DOT, this X amount of pills for 6 months or 9 months. Usually we listen to their concerns. We tell them, it's these amount of pills for 2 months. We go through testing. If you show susceptibility, then we take some off, and then reassure them that at 2 months, if you can tolerate, then we take another few pills off. So I think being very transparent and realistic with them, it does go a long way. And usually in a few days or a few weeks, they'd call back with more questions. And, as long as you're there to help them answer those questions, then, that bond, that rapport starts to build. Once, if someone's an active case, then they pretty much become part of our family too. We see them from beginning to when they're sick, and when they feel better, then then they'll appreciate us a little bit. But we do see a turnaround for them, and they do end up appreciating. And but I think just providing as much education as you can, and just being there for them, and just being available as much as possible.
I'd like to add that we are very available for our patients. They can text us, they can call us, and we'll answer their calls really quickly. I mean, like, it wasn't a joke. Annalie has the phone there, and she will text them back within like 5 seconds of receiving their text. So we're very responsive, and I think that's really important. Actually, we have patients complain about other medical providers because George gives them such good treatment. Why? Yeah, he sets bad expectations. So that's really important. Like George said, transparency and our ability to get back to them quickly is really, really important. We don't let them go down a rabbit hole of, bad thoughts. We try to address their needs and questions right away.
Yeah, I think it's amazing that you do it in order to be available. Are there other resources that you feel would help your patients or help you be able to do your job in the way you'd really want it to? Or other resources that you feel that the patients would appreciate or help support their care?
I think a good concept for TB would be like Meal on Wheels for some of our isolated patients. I know during COVID, people who were in isolation were provided meals. We don't have that unless George is making sandwiches, or we're purchasing other hot foods. We can do it on a regular basis or over the weekend. So that would really be helpful. Yeah, that's a big one, I think, for some of our isolated patients.
Just to add on that, I think, once, like if the patient's on isolation, clearly they can't go out. If they don't have family members, if they don't have friends that can help, then who's going to get their food? I think having, free services like DoorDash or Grubhub or Uber Eats, if those services are provided for patients, that would help them go a long way. And free Netflix, like they said.
Yes, I also learned that free Netflix is going to be key for our future TB care. So to kind of turn it towards the audience, there's a lot of very smart and great researchers here. You saw some of the 3-minute abstracts, and they're trying to figure out good ideas to advance, TB. So if you had the power to have any sort of test or new treatment or anything, what would you want and why?
I want to answer that.
Yeah, please. Yeah, you can answer it.
This is Solima, one of our nurses in the TB clinic.
I think we're so used to working with minimal resources and in poor conditions that they're asking for like Netflix and DoorDash when we need a whole new building. We don't have even access. Like our building, we had to close when it was storming because our windows don't close. It rains in our building. It's freezing cold. Our patients have to walk outside to get to X-ray. So in some cases, we walk them through the basement, which is a scary place to be. And then just this week, it was flooded and had no lights. So this is how we get our patients to and from the chest X-ray, which we know they have to have. We're making do with very minimal resources, and this is such an important disease. And I think that we need much more than just like Netflix, and we need access to and awareness. Like you said, it feels like we're like the stepchildren that's just thrown off to the side and nobody's paying attention to what we actually do. We have people, Janice kind of mentioned, like we have nurses that'll stop at patient's house on the way to work to draw blood, or leave work after work and go dose a patient. So like people are working outside of their hours that we don't necessarily get reimbursed for those kinds of things, or buying food with your own money. These are things that we should not have to do. We shouldn't have to work like that.
Absolutely. I think really having that foundation and is really critical. Thank you so much. Is there anything online that you wanted to?
We have one question on the back.
Oh, sorry. Where? Oh, there it is. Thank you.
Hi. Thank you. I just wanted to thank you all for your hard work, and it seems like you are so compassionate towards your patients and compassionate towards each other. I have two questions. One's a little silly, and maybe you can tell me a little bit more about that. But the first one is, it seems like you're making homemade meals for your patients. I just wanted to hear more about that. What kind of recipes are you making? But also, because I'm hearing, there's a lack of resources, and you're doing, you're going so far above and beyond what your call to action is. How are you, taking care of each other and yourself? Like, how are you prioritizing? Like earlier, we talked about balancing researcher time, like early career researchers, how they're balancing that. How are you all prioritizing yourselves?
The food, well, the patient that I didn't cook all the food, I just some of it. They were newly arrived in the country. They were nauseated. We couldn't tell if it was the medication or aversion to food. And then he's all, it's the hospital food. It just makes me want to throw up. So I wanted to test. Actually, it was, that was the hypothesis. I'm like, okay, let's see, So I brought him some, he was from Nicaragua, so I brought him Mexican food, but that was okay. So beans and tortillas, and he ate and wasn't nauseated. So it was kind of the hospital food, and new foods. He wasn't quite used to the texture, smells, that sort of thing. But we talked to, actually, it happened to be just by luck that I was visiting him when the dietitian called. And so we had a conversation, and so we were able to get him different foods that were a little bit more culturally appropriate. So we cook to figure out, kind of tinker with the side effects. And sometimes the patients just, I think also like some TB medications give you metallic taste or, different things. So if the patient can't think of what else to eat, we just kind of bring them different things so they can experiment. And how do we take care of ourselves? I think post-COVID has been really difficult because we're short-staffed. So as a supervisor, I try to approve all vacation. So, but that's just the beginning. We can work more at taking better care of ourselves.
There's also been a lot of boba in our clinic lately, so that provides a little bit of self-care, I think.
Lisa, I think you have a question.
Yeah, I think, I love these guys. Even you guys sitting in the chairs in here up there. So two thoughts. One was to folks who, you're right. We have boomer generations have not been really good at advocating here or catching the ear of the people who need to listen. And I keep saying, we need different brains doing this. And it's really tough. I mean, all we can say is, oh, look at HIV. They do such a good job, right? And there are advocacy groups. There's Stop TB USA. There's a patient support group that's been out there nationally, and they've got a lot of energy, but they just need allies. So it's there, and it's just, I'm too old fogey to know what to do with the tweet. Come on. In fact, I don't want to support Twitter anymore. So, but we need ideas because we need to get the next generation fired up, because this is not a disease that's gone. And most people think, oh my God, really? This is relevant? Just what you said. So we need people to just dive in. And we need those nursing voices saying, look, we are here on the front lines and we need something different. So I wanted to look at this group and then I wanted to turn up here and I want you guys to appreciate what expertise a clinic like San Francisco, and I know a lot of you on the line are also from really high volume clinics. And what I really noticed the difference between, kind of the life in domestic TB and sometimes when I go overseas is that people do not tap into the power of the nursing groups and the expertise of the nursing groups. In fact, there's often a hierarchy. I've seen nurses try to serve me coffee, right? And yet, where are they at the table? And I want to look at all the researchers in here too. I mean, building up and mentoring, early stage investigators. Have we done that? Have we invested in the people who we know? Anybody who's done TB for a long time, the success of your program lives and dies with your nursing strength. Where are they? Where are we? How are we mentoring up those researchers, those implementation scientists in the nursing field who can kind of teach us a lot, right? All of us. I just want to throw that out there in terms of mentorship. I don't know how often. I used to insist that our technical assistance team was a doctor-nurse team, because if you want to start up an MDR program for your country, in Tanzania, we're bringing over nurse mentors because they're the backbone. But where are they in most of these funding pictures? I don't see them. And so when you guys think about mentorship and needs in the nursing field, I know Razia has a lot of things to say right off the bat. I mean, where would you like to see that go here?
That's a very complicated question. I mean, I think with every day-to-day duties that we have little time to think about research, but we should. And I think partnering up with, researchers and mentoring, we mentor them, they mentor us. It's a two-way avenue. We could accomplish a lot. And there are a lot of things we can learn, even basic. I think it's important for nursing, especially TB nurses, to know a little bit of the epidemiology, the terminology, research, just basic research that we aren't really, they do like one course of research in nursing school and, not very much, but so it's really important. So we can, I think when it comes to research, nurses can be your people that apply, we're applying that you do the research and application, real world application of the research, is done by nursing.
Make it happen.
We'll make it right. We'll make it happen. There you go. We'll make it happen. So we're really good at making things happen. I think nursing is really passionate about that. I mean, my crew is, I mean, we're really, give us an idea and we'll figure out how to make it work.
Well, thank you again. I think, I also reiterate that my own training really benefited from rotating through that clinic and really learning from you. So is there any last words you want to share with the audience?
Just be patient, be humble, be, like I said before, just be transparent and just listen to their needs and do your best to meet them halfway.
A wonderful way to end this a really inspiring session. Let's give another round of applause for our wonderful heroes. All right, it's the moment we've been waiting for. The 3-minute competition winners, who all are winners in my mind, because I learned a lot, and I'm a winner because I learned. But let me pass it on to Sarah.
All right. How are we feeling? One more round of applause to the unsung heroes of the TB field. The nurses have been fantastic. Thank you for all you do. So what I neglected to do earlier is actually acknowledge all of our amazing judges who have been working tirelessly behind the scenes to score these presentations. So I'll ask you to stand up just to identify a target on your back if people are not happy with the scores. So first we have Adithya Cattamanchi, Jonathan Budzik, and Jennifer Flood. All right, so I'll go in reverse order. Honorary mention, Dr. Patrick Phillips. And then tied for second space, Suzanne Dufault, Josephine Reineveld, and Shoshana Jal. So all of our second place winners will get a $25 Amazon card, which will be emailed to you on a code. And then our first prize winner is Ingrid Vigors. And you will receive a $50 Amazon card emailed to you. Thank you everyone for this fantastic day, and thank you for volunteering for the abstract competition. We need more volunteers next year, please.
Thank you. Yeah, okay.
I
So
know, we've got notes.
we have notes. We have to. Right. So that concludes our program, and we're going to now, of course, transition to expressing thanks to those who worked tirelessly to put this together. But before we go there, I just wanted to share some reflections in that, today, I think, I hope everyone here has paused and thought about the work they do in contributing to TB, wherever it is, in the lab or in the field, or with whatever tools you have in your hands, whatever you're good at doing and you're applying it to TB. I hope today inspires you to redouble your efforts, to really ask yourself questions that disrupt what we take for granted as being normative behaviors that we apply to our patients, the expectations we have of our clinics, whether it's in Makerere or it's in the Humboldt County. Why do we have therapies that need DOT? Why do we need isolation in the way that we need it? Why don't we have diagnostics that can clear give us a negative test and then be re-engaged with our social communities? So ask these questions, push yourselves. You're really doing important work in an important area, and I hope that came through from today's really beautiful presentations that have really touched me, and I assume it touched you as well. Hearing the really heartwarming stories from the SF TB clinic nurses brought a little degree of embarrassment for me, as I reflected on how we could be doing a lot more for you to support you in the work that you do. And Janice and I would like to announce that together, San Francisco TB Clinic and the UCSF Center for TB will launch a campaign to generate donation and funding for a TB support fund for the clinic, so that there's never going to be a situation where George or Ali or Rocio have to be pulling money out of your pockets to do this. I think this is a community, and we can contribute to it and act responsibly and help. And that's, I don't know if there's a slide that we'll put up, but we're going to work together to launch a campaign and see where it goes, try to get donations. There is a way to donate to the Center for Tuberculosis, and any monies that are donated today, and frankly, through to the end of the year, we'll give to the TB Clinic Support Fund for the patients that you've just explained.
So I want to express our deep gratitude to the planning committee for really this wonderful design. I mean, today was different than often, the conferences you go to. And I think it brought together the communities from the basic research all the way to the basic human kindness of the clinic. And this is what goes into the recipe for really taking care of with public health needs in TB. So we want to congratulate the planning committee for doing such a fabulous job and really opening our eyes and bringing this forward. We want to especially offer our gratitude to the guests who came. I know Tay Taylor's already gone, but we definitely have benefited from her sharing her wonderful candor and stories and being brave enough to come in front of a bunch of, academics here and public health folks. We want to definitely thank Dr. Achilles Katamba from coming all the way over. I know you would love a cup of coffee now as the jet lag is setting in, but coming all this way to share the highlights of your career, giving us words of wisdom and pearls on true collaboration, what it means to be a collaborator, and I think certainly demonstrating what it means to be an amazing mentor. All of the presenters during the panel sessions, Janice for lifting up the whole afternoon and making it real, right? So our whole row of nurses there, even those that sat there, not up here, you guys, all of you, thank you for taking the time away from clinic. I know that it means you're going to double down later to make up for this time. We really appreciate it. And I want to thank my Curry team, the scores of people in the back, trying to make sure that things keep rolling. They've been here on many off hours, just making sure things get set up. Thank you all. He's got a long set of notes now.
No, there's just so you know the structure, and I know we're coming to the end, don't worry. So the World TB planning event has an oversight committee, and I just want to say thank you to those who contributed their vision. This is in addition to the planning committee, which I'll tell you about at the end, but Lisa Chen, Patrick Phillips, Elizabeth Fair, Susanna Graves, Jenny Flood, Kelly Musoki, Sarah Hutchinson, Barbara Alonso, and Alicia Couchman. Thank you very much. And finally, I'm going to call out the planning committee, and I'd like you to please come up as I call you. So first, Dr. Sarah Solomon, thank you for planning. Being on the planning committee, Dr. Devon Jagannath, Dr. Sophie Huddart, and Dr. Paul Agongo. Sarah and Devon have served on our committee for 2 years now, and will be transitioning out of their role to make room for 2 new members. And Sophie and Paul have graciously agreed to continue, I guess. But I think you guys want to have the closing word, so we'll let you take us up.
So briefly, in our final thank yous, we want to thank the Oversight Committee for trusting us with this somewhat different vision. We hope that you don't regret it. It's too late now. And so this is really an open call. If you liked what you saw today and you want to join us, Paul and I'd be so excited. If you have ideas for how to make it better, we would love to hear that too. But the last and most important set of thank yous we have to make are to 3 people without whom anything that happened related to TB at UCSF or the Curry Center would not happen. As far as we are concerned, they make the world go round. And that's Alicia Couchman, Sarah Hutchinson, and Barbara Alonso. They have been with us every step of the way, and then they have run several marathons in between. And not only are they exceptionally good at their jobs, but they are so wonderful to work with. And I want to assure you that behind the scenes, they showed such compassion and grace to our TB heroes, to our patient advocates, to everyone, to make sure that they felt comfortable sharing their stories and that they were able to come here and make those perspectives heard. So today happened because of them. Thank you all for coming. Thank you everyone who helped in the planning, and have a great day. We really enjoyed this. Hope you did too.